Hopefully I'm audible now. Yeah, they are working on the screen. It will appear, don't worry. Chalo. So welcome back. Good evening, all of you. Let's start our next session. Now let's start with DVT. Now let's start with veins. Arteries are done. Okay? So if I talk about veins, definitely, I've told you that in lower limbs, in our legs, अपने पैर में definitely there are two systems of veins. One is the deep venous system, second is the superficial venous system. First of all, let's talk about the deep venous system of leg, that is known as DVT बच्चे. Okay, so deep venous system of leg में क्या होगा condition, that is DVT we have to discuss. What is DVT? Deep venous thrombosis. Now we know already thrombosis is nothing but a blockage itself. Thrombus is nothing but a blockage which will be formed in the leg. What is the basic difference between thrombosis and atherosclerosis? We know that atherosclerosis में along with the thrombus there is also collection of a lot of foam cells, fatty streaks. Okay, fat की वजह से होता है वो blockage. But usually thrombosis is purely a blockage which will occur due to the blood cells like platelets, clotting factors, fibrin, right? That is the basic difference. So if I talk about DVT, it is nothing but deep vein thrombosis. So क्या हो जाता है, लेग के जो deep veins है उसमें thrombus बन जाता है, उसमें blockage बन जाता है. Now important is, as I've told you, the most common site is definitely the lower limbs, and in the lower limbs definitely it is which region of the lower limbs? It is mainly the calf of the lower limbs. Okay, calf जो होता है ना definitely, okay, that calf is the most common site of your deep venous thrombosis. And which veins are commonly affected? You have to remember the calf veins, that is known as the soleal veins. So these soleal veins are commonly affected. Okay, so the calf veins or the soleal veins are the most common site which are affected with deep venous thrombosis. They are affected with deep venous thrombosis. No issues with this, anybody? Now, what is the cause of a thrombus formation? Thrombus banta क्यों है? Why a blockage is actually formed at first place in a vessel? So you have to remember, from pathology you might be able to recall there's a classical triad given by Dr. Rudolf Virchow. He has given a classical triad of thrombosis. He has said there are three important factors which will lead to thrombus formation inside a vessel. And what are these three important factors of Virchow's triad? So this Virchow's triad says the first factor of the triad is nothing else but endothelial injury. Yes, for example, the endothelium of the vessel, that is the inner layer of your vessel, bache, if it is damaged or if it is injured, that is considered as the screen lag. Okay. Now it will appear, don't worry. Okay, chalo. So definitely the first part of your Virchow's triad is definitely your endothelial injury. The second part of the triad which is there, important you have to remember, is the stasis of blood flow. Okay, why stasis of blood flow? Important is, for example, stasis means what? Blood एक जगह रुक गया है, तुम्हारा ब्लड आगे नहीं बढ़ रहा ढंग से, तुम्हारा ब्लड एकदम धीरे धीरे चल रहा है या ब्लड एक ही जगह रुक गया है. Definitely if there is stasis of blood flow बच्चे, therefore definitely the chances of clot formation or the chances of thrombus formation are definitely going to increase. That is the reason. ठीक है. And third important is the hypercoagulable state, or we can even call it as hypercoagulability. Important is hypercoagulability is what? Increased chances of clot formation. The blood which will have increased chances of clot formation or thrombus formation is called as a hypercoagulable blood, or that condition is known as hypercoagulability. Okay, why? Because please remember, the blood over here becomes more thicker, the blood over here becomes more viscous. Okay, ज्यादा गाढ़ा हो जाता है ब्लड, और जब ब्लड ज्यादा गाढ़ा हो जाएगा तो उसके क्लॉट बनने के चांसेस ज्यादा हो जाएंगे. ठीक है, सो दैट यू हैव टू रिमेंबर. देयर आर थ्री फैक्टर्स व्हिच आर रिस्पांसिबल फॉर अ थ्रोम्बस फॉर्मेशन: एंडोथेलियल इंजरी, स्टासिस ऑफ ब्लड फ्लो एंड हाइपरकोएगुलेबिलिटी. अगर इन तीनों में से सबसे इंपॉर्टेंट फैक्टर पूछे, इफ दे आस्क यू द मोस्ट इंपॉर्टेंट फैक्टर आउट ऑफ ऑल ऑफ देम इज व्हिच वन, प्लीज लेट मी नो दैट. ठीक है, सो व्हेनेवर देयर इज अ injury of the endothelium, for example, see, if there is injury of this endothelium, what is going to happen? The von Willebrand factor which is over here, it is going to attract all your platelets. So all your platelets will be attracted and all your platelets are going to attach over here. Okay, all your platelets will come and they are going to aggregate, they are going to collect over here. Okay, next important, definitely once the platelets will come together, then after that a fibrin is going to come, and that fibrin is going to form a mesh around this clot, making this clot more stronger, right? That is going to happen, and that finally leads to formation of a thrombus also usually. ठीक है? Most important component is endothelial injury for this. ठीक है? तो याद रखना है बात. Important is what is the most common cause for DVT then? Okay, thrombus formation का तो पता चल गया. Okay, so definitely thrombus formation can occur due to these three reasons. Most important, as I've told you, endothelial injury, but other causes can be stasis of blood flow or hypercoagulability. So for example, if a patient is having stasis of blood flow, blood उसका आगे ही नहीं बढ़ पा रहा, the blood is not flowing over here. What is that condition? It is usually prolonged immobilization. What do I mean by prolonged immobilization? That means a patient who is not moving, a patient who is lying in the bed whole time, a patient who is actually lying in the bed for a very long duration of time, he is not able to move. Now this patient who is constantly lying in the bed for a very long duration of time, definitely what will happen? The blood inside his lower limbs, the blood in his in the deep veins of his lower limbs is not going to move. Reason is, जब तुम चलते हो, whenever you walk, the muscles will contract, and as the muscles contract, these calf veins, these soleal veins are also going to contract, and therefore the blood will move properly. But whenever you are not walking, definitely you are only lying for months together, what is going to happen? All that blood will be moving on, but that blood will be very slowly moving. There will be stasis of the blood flow, and due to that, definitely the chances of clot formation or thrombus formation are going to increase. So you have to remember the most common cause for DVT has to be prolonged immobilization. Now, what are the conditions which can cause prolonged immobilization in a patient? Why are these important? Because they will not write prolonged immobilization in the question. They will either give you some hints for prolonged immobilization. क्या होंगे वो hints? Either a patient who is bedridden. Okay, they can say the patient who is usually bedridden, वो जगह से हिल भी नहीं पाता. So it can be a bedridden patient, or it can be what? Definitely a patient who is admitted in the ICU. Okay, it can be a patient who is admitted in the ICU usually. ठीक है? Or it can be a patient definitely. Sorry, if it can be a patient who has had a fracture, usually which kind of a fracture? For example, a long bone fracture, like a shaft of femur fracture, neck of femur fracture, vertebral fracture. Definitely these patients which are there, they are not able to walk for a longer duration of time, they need bed rest. So these patients usually again, okay. Apart from that, patients who are actually taking a long flight, okay, patients who are taking a long flight, definitely if they take a long flight like from New York and Delhi, okay, New York to Delhi is the flight, and they're not walking in the flight for all that 12 hours or 14 hours, they're always sitting. So due to that, definitely there will be stasis of blood flow, and the chance of clot formation is going to increase. Okay, so definitely, or a patient after a major surgery like TKR or a THR, that is major surgery like a total hip replacement, total knee replacement surgery. Okay, then also you might have studied, right? Definitely a patient who is having some muscle weaknesses like muscle dystrophies ho gaya. Okay, so all of these conditions, multiple sclerosis, yes, all of these patients definitely who are having any kind of muscle dystrophy or muscle problems, they are having paralysis, all your paralysis wala patients, okay? They are having high chance, as they are not walking, they are lying in the bed for a longer duration of time, therefore the chances of stasis of blood flow are higher, and therefore the chances of clot formation or thrombus formation are also very high in this patient, right? So these are the conditions which can predispose to DVT immediately. इनकी वजह से DVT हो जाएगा immediately, but there should be risk factors also ना, which should be present. ऐसा तो है नहीं कि only any person who is taking a long haul flight and that person has not walked in the flight for a longer duration, he will develop a DVT. No, not all patients will develop DVT. So there should be some important risk factors which are responsible. So the risk factors which are responsible for DVT, the most important risk factor, this was the previous year question, most important risk factor is what? The most important risk factor is the previous history of DVT. Yes, if the patient has had a previous episode of DVT, that patient will have the highest risk of developing DVT again. So previous history of DVT. Second is pregnancy. I hope all of you are quite aware, bache, that pregnancy is a hypercoagulable state, right? So definitely pregnancy is a hypercoagulable state. That means all the clotting factors in pregnancy increase except clotting factor 11 and clotting factor 13, right? So you have to remember that all the clotting factors are going to increase. So definitely the thickness, the viscosity of the blood is going to increase, and therefore the blood will be more coagulable, more chances of thrombus formation. Next, malignancy. Malignancy is also a procoagulable state or a hypercoagulable state. You have to remember malignancies or cancers also increase the risk of clot or thrombus formation. Okay? Next is protein C or protein S deficiency. Now protein C or protein S, both are natural anticoagulants of your body. Just like antithrombin 3, you might have studied about antithrombin 3 na. Where protein C and protein S are also the anticoagulants of your body, natural. But if there is deficiency of these anticoagulants like protein C and protein N, definitely the chances of coagulation or chances of thrombus formation are going to increase. Next is factor 5 lead-in mutation. Factor 5 lead-in mutation is actually a genetic mutation due to which the chances the blood is going to become more viscous. There will be hypercoagulability due to actually a mutation in the clotting factor number 5. Okay? That's the important thing. Now, these are the important risk factors that you have to be aware of. So they will mention a risk factor in the question, they will mention a cause in the question. That means, like, the question will start as a young female who is, for example, 36 weeks pregnant, has taken a long haul flight from New York to Delhi, and now after getting down from the flight, she starts experiencing respiratory distress or breathlessness. Got it? So that is a classical case of DVT. You will say, sir, ये respiratory distress or breathlessness कहाँ से आ गया? Because she is having thrombus in the lower limbs. I'll come to that. Okay, why it happens? I'll come to that. Now, first of all, when a patient develops deep venous thrombosis, बच्चे, definitely you know that there is a blockage in the there is blockage in the deep veins of the lower limbs. As there is blockage in the deep veins of the lower limbs, definitely, what is going to happen? Now, blood in the vein goes from the periphery towards the heart, right? It goes from periphery towards the heart. ऐसे जा रहा है ना? So now, as there is increased blood pressure over here, you have to remember, due to that, definitely the patient will have swelling over here. Why? Because if there is increased blood pressure inside the vessel, what happens? The fluid is kicked out of the vessel. The fluid starts getting kicked out of the vessel, right? Agar pressure andar badhta hai, all that fluid is pushed outwards. Okay, so that is what is leading to swelling, that is edema, right? So there will be swelling or edema in the calf region. Along with that, there will be slight pain as well in the patient. Okay, so you have to remember, bache, definitely the most common and the earliest symptom of a patient of DVT is going to be pain and swelling in the calf region. The patient is going to have swelling and pain in the calf region. Okay, pain and swelling in the calf region is a classical finding seen in a patient of DVT, that is deep venous thrombosis. Next important is the patient was having pain and swelling due to DVT, but now what has happened is, now this patient suddenly started experiencing chest pain and there is dyspnea. Now this patient suddenly started experiencing chest pain and dyspnea. What is the cause? Now the cause is, bache, this thrombus which was there in the deep veins, it has got separated. This thrombus, it has got separated, it has got dislodged. ये अलग हो गया thrombus उस vessel से, and now it has started traveling upwards. It starts traveling upwards. It goes to the heart. From hearts, it goes to the lungs, definitely. And as it goes to the lungs of the patient, bache, definitely it is going to block the small blood vessels in the lung. It is going to block the small blood vessels in the lung, and that is the reason why some parts of the lungs where there is blockage, they will not receive enough amount of blood supply, and that condition is what is called as pulmonary embolism. That condition is what is known as the pulmonary embolism. Sedentary lifestyle is also one of the risk factors. Yes, it is one of the risk factors which can lead to this. I'm not sure about the screen, just a minute. Hopefully now it would be fine. Hopefully now it will be fine, bacho. Okay? So now, as you can see over here, see, important is the thrombus which was there from the deep veins of the leg, definitely this thrombus has got separated, or this thrombus has got dislodged from here. यहाँ से अलग हो गया, and now it will go in the small blood vessels of the lungs, and it is going to block those small blood vessels. As it is going to cause the small blood vessels, it is going to cause blockage in the small blood vessels of the lungs, and that too suddenly. Therefore, this is what is called as pulmonary embolism. Okay? So therefore, a patient of DVT can come to us in the emergency with complaints of pulmonary embolism. And how the patient will present to us? As there is a sudden blockage in the pulmonary blood vessels, the patient is going to have difficulty in breathing. There will be dyspnea. Along with that, there will be a sudden and a severe chest pain in the patient. Therefore, as the patient has sudden and severe chest pain along with breathlessness, it can be a differential diagnosis for myocardial infarction. So you will do definitely ECG in this patient, and the ECG usually comes out to be normal if it is a case of submassive pulmonary embolism. Massive mein there is a classical S1 Q3 T3 pattern that you will study in definitely medicine. Okay, so pulmonary embolism is a topic that to be studied over there. So definitely if you talk about a patient of DVT who comes to you with the chest pain and dyspnea suddenly, it has to be a case of pulmonary embolism. It has to be a case of pulmonary embolism. Okay, so that's the important thing you have to be aware of. The complication of DVT can be pulmonary embolism, that has to be remembered. Okay. Important is now, we'll move further. Here on examination, when you have to examine the patient of a DVT, what are we going to do? See, important is we will try to dorsiflex the foot. For example, can you see this is the foot of the patient, we are trying to dorsiflex the foot. Okay, passive dorsiflexion. Okay, उसको मोड़ने की कोशिश कर रहे हो. You are trying to dorsiflex the foot, and when you try to dorsiflex the foot, you can try with yourself as well. You can see there is stretching of these muscles over here. There is stretching of the calf muscles. But now as the patient is having DVT, here there will be a lot of resistance. The patient will feel a lot of stiffness, or the patient will feel a lot of resistance in the calf muscles. Okay, that is classically known as the Homan sign. That is what is known as the Homan sign. And second, definitely, when we press this calf muscles, the patient will have pain in the calf muscles. That is what is called as a Moses sign. For example, see, consider this as your leg and this as your foot. Okay, you are causing dorsiflexion of the foot. You are causing dorsiflexion of the foot. Then you will experience a lot of stiffness or resistance over here. Okay, that is the Homan sign. Second important, when you press the calf muscles, obviously there is DVT over there. So when you press the calf muscles, there will be pain over there. That is what is called as the Moses sign. Okay. So these are the classical signs of DVT bache. So dorsiflexion of foot causing resistance is known as the Homan sign. It is known as the Homan sign. Whereas squeezing of the calf causing pain is what is caused as the Moses sign. It is classically known as the Moses sign. कोई दिक्कत नहीं यहाँ तक. So that is the important features that you have to be aware of. Now important is, once you have examined the patient clinically, then you have to do investigation of choice. What is the investigation of choice? I have told you, superficial veins, though they are deep veins in the leg, but then also they are present in the limb itself. Okay, there are not so many organs that you cannot see them with the help of a Doppler. So therefore investigation of choice is always a duplex scan over here, Doppler plus the ultrasound B scan. So investigation of choice for DVT is also a duplex scanning because a non-invasive technique. So here also investigation of choice is a duplex scan. Important is, now once we have assessed the patient with a duplex scan, then definitely what will be the management of the patient? What will be done for the management of the patient? So management की बात करूँ तो, sorry, if the patient comes to us with an episode of DVT, episode मतलब severe pain in the calf and severe edema or swelling in the calf region, that is a classical case of DVT. How the patient is going to come to us either in the OPD or in the emergency. ठीक है. Management will be done with the help of anticoagulation. Why? Because there is clot formation or thrombus formation in the vessel. So definitely we need anticoagulation in that person. So when the patient comes to us in the emergency, what is the first line management? The first line management is going to be definitely, we will give a low molecular weight heparin. Yes, injection of low molecular weight heparin, IV, low molecular weight heparin. Subcutaneous भी दिया जा सकता है. But in emergencies, we prefer low molecular weight heparin IV. Plus, along with that, definitely. See, important is in this condition, gold standard to angiography ही करोगे, but usually it is not required in this condition. Not required for DVT. Okay, even a duplex scan can tell you about DVT. ठीक है, तो करते भी नहीं है हम angiography. So, now anticoagulation की अगर हम बात करें, please remember IV low molecular weight heparin is given plus warfarin is started. So you will say, sir, definitely why we are starting both of them? बच्चे, important is, first of all, warfarin is the anticoagulant of choice that you have to give to this patient, because warfarin is an oral tablet that you can continue in the patient afterwards also. But in the emergency, when the patient has come to you, will warfarin starts its action immediately? No. हमने ये पढ़ा होगा कि warfarin usually takes 5 days to act. Warfarin का onset जो होता है usually takes 5 days. That is the reason why we start warfarin on the first day itself. Okay, so that the effect is usually seen from 5th day. ठीक है, that is the reason we have to start warfarin along with heparin on the first day itself. ठीक है, so intravenous low molecular with heparin, and we know anticoagulant of choice for maintenance is warfarin because it is oral drug, but anticoagulant of choice in emergency in acute condition it is heparin. ठीक है, so here we have to start both of them, low molecular weight heparin plus warfarin when the patient comes for treatment of DVT in the emergency. Got it? So that's the important thing. Then this is given for how many days? As I've told you, this is given for a span of 5 days. And after 5 days, what are we going to do? After 5 days, continue the patient only on warfarin. After 5 days, mostly you are going to discharge the patient. Then just continue warfarin. Then just continue oral warfarin. Okay, that is tablet of warfarin continued. Okay, till 5 days give both of them, but after that definitely just continue oral warfarin. Now what should be the duration of this treatment? What should be the duration? Pain while walking symptoms हो सकते हैं, but important is in a patient of DVT there is a constant dull aching pain. Okay, pain while walking is more likely a feature of arterial या intermittent claudication. यहाँ पे pain while walking definitely हो सकता है, ज़्यादा होगा, but a constant dull ache which is present usually in a patient of DVT. That is how you differentiate it. ठीक है, constant dull ache is always present. ठीक है, now important is definitely in a patient of DVT the treatment duration will be continued for what time. So if it is the first episode, of DVT, you have to remember the duration of the treatment will be how much. So the duration of the treatment will be 3 months. Yeah, you have to continue the warfarin tablet for a span of 3 months if it was the first time the patient had episode of DVT. If it was the first episode of DVT, the warfarin treatment initially it was 6 months. Last time अभी recent edition of BD says clearly it is 3 months. ठीक है, तो याद रख लो duration of treatment for the first episode of DVT has to be 3 months बच्चे. And if it is a case of recurrent DVT, that means the patient has come to you in the second time or third time with DVT. For a recurrent DVT, then you have to continue warfarin lifelong. In this patient. Yes, either you can give a lifelong warfarin in the patient, or if you want to prevent because if this patient is developing DVT on a recurrent basis, there are very high chances कि चलो अभी तो DVT है, but there are very high chances that this patient can have what? This patient can develop pulmonary embolism. क्यों? This patient is always having that thrombus inside his deep veins of the leg, and whenever this patient will start walking after a long bed rest, okay, he is taking a lot of bed rest, then he starts walking. Now the thrombus has been formed. As he starts walking, the muscles of his legs start contracting. As the muscles of his legs start contracting, therefore these veins also start contracting. Therefore the thrombus gets dislodged. The thrombus अलग हो जाता है, and it can go and cause pulmonary embolism. Therefore usually the patients who are taking a long flight, when they are sitting in the long flight, they will not have problem. When they get down from the flight and when they start walking after a prolonged immobilization, that is the time this thrombus will go and block the lungs. Got it? So that is the reason after they get down from the flight, they will have this symptom. So here definitely as the patient is having recurrent episodes of DVT, there are very high chances of pulmonary embolism. So in this patient, to prevent that, we can use we can place a IVC filter. Okay? So we can actually use a IVC filter in this patient. Now what is the role of this IVC filter? As I have told you, it is to prevent pulmonary embolism. It will prevent pulmonary embolism in the patient. So it will prevent pulmonary embolism in the patient. You have to remember, we have to place a IVC filter. What is the IVC filter now? See, for example, definitely the thrombus which gets separated from the deep veins of the leg, it is going to the inferior vena cava, from there to the heart, and from heart say lungs tak. So definitely in the inferior vena cava itself, we are going to place a IVC filter like this. It is something like a mesh or an umbrella. Definitely. So for example, if a thrombus goes from the deep veins even, okay, if a thrombus goes usually from a deep vein, it gets destroyed over here. That thrombus will get disintegrated. That thrombus will get usually broken down. टुकड़े टुकड़े हो जाएंगे उसके. It will get trapped in this IVC filter usually. ठीक है? So that's the important thing. Other parts से severe bleeding होने का reason बच्चे, ब्लीडिंग क्यों होगा? उल्टा क्लॉट फॉर्मेशन की रिस्क ज्यादा है ना इस पेशेंट में. तो देयर आर मोर इंपॉर्टेंट फीचर्स. एंड वारफेरिन के लिए, वारफेरिन क्या अच्छा, वारफेरिन एंटीकोएगुलेशन ट्रीटमेंट के लिए बोल रहे हो, तो यू हैव टू रिमेंबर एंटीकोएगुलेशन ट्रीटमेंट जब भी देते हो वारफेरिन के लिए, यूजुअली स्टडी इन फार्मा, यू हैव टू मेंटेन दैट आईएनआर रेंज बिटवीन 2 to 3. ठीक है, पीटी आईएनआर तुम्हें रेगुलर मॉनिटरिंग करना पड़ता है. व्हेनेवर यू गिव वारफेरिन टू अ पेशेंट, यू ऑलवेज हैव टू डू अ रेगुलर मॉनिटरिंग ऑफ पीटी आईएनआर ऑफ दिस पेशेंट. और पीटी आईएनआर का जो रेंज होता है मैक्सिमम, इट शुड बी मेंटेन बिटवीन 1 to 2. सो दैट इज द रेंज दैट यू हैव टू मेंटेन, ठीक है। तो रेगुलर मॉनिटरिंग करते हो जब भी वार्फेरिन थेरेपी देते हो पेशेंट को, ठीक है। So prevention of pulmonary embolism के लिए, or in a case of recurrent DVT, you have to place what? You have to place a IVC filter. Now, important is to prevent DVT itself. To prevent DVT itself, definitely, what are we going to do? So for prophylaxis of DVT, okay, for prophylaxis of DVT, ये तो treatment की बात हो गई. Now for prophylaxis or prevention of DVT, what are we going to do? Now prophylaxis can be of two types. You have to remember. One can definitely be a pharmacological prophylaxis, which is better. Definitely pharmacological prophylaxis will always be better, and pharmacological prophylaxis mein we have to give low molecular weight heparin. In pharmacological prophylaxis we can give the best drug which can be given as a low molecular weight heparin, but as we know it is an injectable drug, so not commonly preferred. It is only given in patients who are at a very high risk. For example, a patient who is admitted in the hospital and he is in the ICU and he has undergone a major surgery. Usually after surgery तुमने surgeons को सुना होगा, what do we say? We usually say definitely कि please start walking on the first or second day itself as soon as possible. As even after a surgery, the patient is asked to start walking as soon as possible. Reason is, I've told you two reasons for that. First was a pressure sore, right? Because due to bed rest, constant bed rest, definitely the patient can have pressure sores. And second important is the risk of DVT. Okay, the risk of DVT is there always in the patient. ठीक है? तो risk of DVT होता है सर्जरी के बाद. इसीलिए बच्चे we always ask the patient to walk as soon as possible, so that definitely there is no stasis of blood flow after surgery and the patient will not have a higher risk of DVT. ठीक है, अदरवाइज हमें पता चला हमने सर्जरी से तो बचा लिया पेशेंट को, बाकी कोई कंडीशन है पेशेंट बेचारा मर गया पल्मोनरी एम्बोलिज्म से, दैट शुड नॉट हैपन. ठीक है, देयरफॉर early ambulation is very much recommended after a surgery, okay, unless and until there is a contraindication. But as I've told you, the patient underwent a major surgery. Okay, for example, exploratory laparotomy. Now, after exploratory lap, the patient cannot walk on the first or the second day itself. The patient has to be in the bed for at least for 5 to 6 days. So, in that condition, you know definitely the risk of DVT is going to increase. So, for such patients, if you feel the risk of DVT is too much high, you can either go for a mechanical prophylaxis or you can go for a pharmacological. The pharmacological prophylaxis, उस patient में you can start something like low molecular weight heparin. ठीक है, उस patient में थोड़े time के लिए at least for those 5 days you can start low molecular weight heparin. Okay, but that is not commonly recommended. What is commonly recommended is the mechanical prophylaxis. And what do we do in the mechanical prophylaxis? This has been a previous year question as well. So mechanical prevention of prophylaxis में first thing that we always recommend, as I've told you, is definitely early ambulation after surgery. कि भाई जल्द से जल्द चलना शुरू कर दो after surgery. And second important thing is this has been a previous year image based question. This same has been asked in the examination. बच्चे, can you see these are the compression stockings which are generally used? Yes, these are actually the compression stockings. And what does this signify? ये जो machine है, definitely with the help of this machine or the regulator you can actually control the pressure of these pneumatic compression stocking. Why I'm calling them pneumatic? Pneumatic because whenever you press the button, definitely here after certain interval ना हर 2 घंटे में क्या होता है, usually इसमें हवा भर जाती है, and जैसी हवा भर जाती है it is going to compress your leg muscles. As it compresses your leg muscles, बच्चे, definitely due to compression of the leg muscles, the deep veins of the leg are also compressed, and there is no stasis of blood flow. Due to compression of the muscles ना there is no stasis of blood flow, blood keeps on flowing. ठीक है, that is the reason we have to use these pneumatic compression stockings. अगर ये नहीं होगा, we can use just the normal stockings as well. और अगर वो भी नहीं होगा, बहुत गरीब patient है, you can ask his family members or his attendants to always actually keep on pressing his calf gently. ज़्यादा जोर से नहीं. Okay, ask his attendants to keep on pressing his calf or doing a physiotherapy in his legs regularly. ठीक है, so वो करते रहना after surgery. ठीक है, this is nothing else but pneumatic compression stockings बोलते हैं इनको. These are classically called as the pneumatic compression stockings. ठीक है, pneumatic compression stockings. Please remember the image that has been asked. No issues with this anybody बच्चों? That's the important thing. Pneumatic compression stockings they are. ठीक है, that was all about your DVT. Once we are done with the DVT, now let's try to understand varicose as well. Let's try to understand varicose as well. Varicose के लिए first I will like you to understand the basic funda behind varicose. ओके सबसे पहले द नॉर्मल बेसिक एनाटॉमी थोड़ा सा स्टार्ट करते हैं. इंपॉर्टेंट इज प्लीज रिमेंबर in deep in the leg or in the lower limbs, I have told you there are two kinds of veins, right? First definitely are called as the deep veins. Okay, first are definitely called as the deep veins. Okay, and second are definitely called as the superficial veins. Okay, second are definitely known as the superficial veins. Okay, second are definitely the superficial veins. These deep veins and the superficial veins बच्चे they are connected by some something in between. ठीक है, so ये तो हो गई तुम्हारी deep vein. As you can see the deep veins are larger in size. Okay, and they carry almost 80% of the blood from legs. They carry almost 80% of the blood from the legs itself, whereas the superficial veins, can you see, they are very thin, they are very small in size, and they only carry 20% of the blood. They only carry 20% of the blood. Now important is you have to remember that these deep veins and the superficial veins, they are connected at the junctions. Okay, the deep veins and the superficial veins now they are connected at some site. That site can also be called as a junction. When the deep vein and the superficial vein are connected to each other, these can be called as junctions, or we can call these as perforator. Agar small honge connections, that is a perforator. But if there is a direct large connection, that means one deep vein combining with another superficial vein, that one will be called as a junction directly. ठीक है, बट अगर छोटे छोटे वेसल्स के साथ कनेक्टेड है, that is what is a perforator. ठीक है, that's the important thing. So the site of connection between the deep vein and the superficial veins of the leg is either the junction or it is a perforator. Now junctions जो होते हैं बच्चे वो दो टाइप के होंगे. Now for example that you have to understand, there are deep veins like there will be a femoral vein, that is a deep vein. Then at the level of knee there will be popliteal vein, that is a deep vein. ठीक है, short or definitely if I talk about the superficial veins कौन सी होंगी? deep veins में I have told you femoral vein होगा and popliteal vein होगा. superficial veins में कौन सी होंगी? great saphenous vein होगी और short saphenous vein होगी. great saphenous vein and short saphenous veins are the superficial veins of the leg. Have you understood that? This is the basic one. Now I've told you that the deep veins are connected to the superficial veins. deep और superficial veins के बीच में कोई connection होता है. तो the femoral vein is connected to the great saphenous vein. The femoral vein is connected to the great saphenous vein, and that junction is called as the saphenofemoral junction. When great saphenous vein connects with the femoral vein, that junction is called as the saphenofemoral junction. Right? Next important is my popliteal vein is connected to my short saphenous vein. My popliteal vein is connected to my short saphenous vein, and that junction can be called as saphenopopliteal junction. That junction, when my short saphenous vein connects with my popliteal vein, that junction will be called as my saphenopopliteal junction. Got it? So that's the important thing you have to be aware of. Important is बच्चे this saphenofemoral junction which is there. Okay, femoral vein का होती है almost at the level of thigh. So saphenofemoral junction is present over here somewhere. ठीक है, at the level of the groin region somewhere in the femoral region. Whereas the saphenopopliteal junction which is there, it is usually present at the level of the knee. The saphenopopliteal junction which is there, it is usually present at the lateral part of the knee. यहाँ से होता है, ठीक है? So that's the important thing. So saphenofemoral junction, you can remember, it is present at the level of groin region, whereas saphenopopliteal junction it is present at the knee region. ठीक है, तो ये याद रखना. And now this were about the junction. We also have perforators. The connection can also be done by perforators. Now you have to remember perforators की अगर मैं बात करूं, at the level of the thigh, the perforator that is present बच्चे, it is known as the Hunterian perforators. Okay, at the level of the thigh, the perforators which are present, they are called as the Hunterian perforators. Then definitely below the knee, okay, below the knee the perforators which are present, they are called as the Boyd perforator. Below the knee the perforators which are present, they are called as the Boyd perforator. And then definitely above the medial malleolus, we have two perforators. One is definitely called as the Dodd perforator and second is called as a Cocket perforator. Okay? So these are the usual perforators that you have to remember. बस इनके नाम है. वैसे तो usually in the lower limb there are 100 to 150 perforata. Yeah, in one lower limb there are almost 100 to 150 perforata, but the larger perforators are these one which have been given the name. At the level of the thigh there is a Hunterian perforator, below the knee there is a Boyd perforator, above the medial malleolus definitely there is two perforators known as the Dodd perforator and the Cockett's perforator. Got it? That's the important thing. Now Have you understood? There is a connection between the deep vein of the leg and the superficial veins of the leg. Now definitely we all are quite aware that usually the veins are going to have valves. Okay, every vein usually has valves except few. So definitely the veins are going to have valves. Why? Because in veins the blood is flowing from the lower part of the body to the upper part of the body. It is flowing back to the heart. As the blood is coming back to the heart, it is coming in the anti-gravity direction. Anti-gravity जा रहा है ना भाई blood. So there will be again pull back from the gravity. Therefore, to actually prevent that pull back, we have these veins in the we have these valves inside the veins, right? So every veins usually has valves. Every veins usually have valves. That has to be remembered. No issues with this, anybody? That's the important thing. Now these valves are also present at the level of the junction of the perforator. Yeah, these valves are also present at the level of the junction of the perforator because they will allow only unidirectional movement. एक ही तरफ वो movement होने देगी blood की. तो बच्चे ये जो valves होते हैं, they are usually present between the deep veins and the superficial veins. They are usually present between the deep veins and the superficial veins. Now, why they will allow only unidirectional movement? Let's see. See, whenever you will start walking, the muscles of your leg are going to contract, and as the muscles of the leg will contract, which veins are going to be compressed first? If the muscles of your legs will be contract, which veins will be compressed first? Please tell me that. जब तुम चलोगे, the muscles contract, which veins will be compressed first? The deep or the superficial? The deep or the superficial? Anybody? मसल्स कॉन्ट्रैक्ट करेंगे ना बच्चे, मसल्स कॉन्ट्रैक्ट करेंगे तो पहले सुपरफिशियल कंप्रेस होंगे फिर डीप कंप्रेस होंगे ना, राइट? डायरेक्ट डीप कैसे कंप्रेस कर रहे हो? मसल्स कंप्रेस करेंगे तो पहले सुपरफिशियल वेन्स कंप्रेस होंगे ना. Yes, so first it is the superficial veins which are going to be compressed, and as the superficial veins are going to be compressed first, then definitely you have to remember the blood from the superficial veins is going to flow inside the deep veins. The blood from the superficial veins is going to flow inside the deep veins. ये पूरा का पूरा blood superficial veins से कहाँ आएगा? Deep veins में आएगा. We know that deep veins are larger in size. They don't have any problem. They can accommodate a lot of blood क्योंकि thick होती है उनकी wall and they can accommodate a lot of blood. No issues with that. But in some patients, what is going to happen now? In some people, you have to remember, बच्चे, what is going to happen? These valves which are there ना, these valves are either defective. ये valve खराब होती है. These valves are either defective or these valves are not present at all. Yes, these valves are absent. Okay, either the valves are defective or the valves are absent. Now, what is going to happen? Let's see. If the valves are defective or the valves are going to be absent, definitely there will not be only a unidirectional blood flow. There will be a bidirectional blood flow. मतलब blood आएगा भी और जाएगा भी. That is what is the problem. Now what is going to happen in this patient? See, now जब भी there will be increased pressure in the deep veins. Whenever there will be increased pressure inside the deep veins, definitely we know the pressure in the deep veins will be more because there is 80% of blood supply in the deep veins itself, whereas only 20% blood is present in the superficial vein. Therefore in the superficial vein the blood pressure will be low. Therefore all that blood, as the valves are not present now, all that blood which is there, bache, it can easily go inside the superficial veins. So whenever the pressure inside the deep veins is going to increase, all that blood will be directed towards the superficial vein. But important is, are your superficial veins in a state to handle this excess amount of pressure? तुम्हारे superficial veins में इतनी जान है क्या कि वो इतना blood pressure संभाल पाए? नहीं, because they are very very small. They are only used to handle 20% blood. But now so much of blood is coming from the deep veins. Therefore, these superficial veins will start dilating. As they are not able to handle a lot of pressure, therefore these superficial veins, okay, they will start undergo dilatation. They will start dilating. Okay, and now when there will be more and more and more dilatation, they will not remain straight. They will not remain straight. तो ये टेढ़े मेढ़े हो जाएंगे. They will become टेढ़े मेढ़े. That is tortuous. Okay, so please remember, these superficial veins will become dilated due to excess amount of blood pressure, and they will become tortuous. These dilated, tortuous veins is what is called as the varicose veins. Got it? So this dilated and the tortuous veins, bache, is what is going to be called as the tortuous veins. Got it? So please remember this. No issues with this, anybody? That has to be remembered. कोई दिक्कत नहीं है. So please remember, these dilated tortuous veins are going to be called as the varicose veins itself. समझ गए? Okay. Hopefully you have understood the concept of varicose. A lot of people are confused with varicose itself. कि varicose क्यों होता है, क्या होता है, समझ नहीं आता. Hopefully now it's clear to all of you, because if it's clear then it will be easier to understand varicose. Okay? And varicose is important topic of your exam. Now important is बच्चे, if I talk about varicose veins now, chalo great. If I talk about varicose veins, so we have discussed already that varicose veins is nothing but abnormally dilated and tortuous veins, that is stadium media. Okay, so abnormally dilated and tortuous veins with defective valves. Now that defective valve can be either a absent valve or it can be an incompetent valve. Okay, defective valve का मतलब क्या? Either it is an absent valve, okay, or it is an incompetent valve. Now what is competence? लायक. Incompetent मतलब नलायक. Yes, तुम्हारे valves are incompetent, मतलब they are not at all useful. नलायक valves से कोई मतलब नहीं है इनका होते हुए भी, ठीक है. Definitely they are allowing both side का blood supply, blood flow. That is the problem. Okay, so they are incompetent valves. So most of the times you will hear valvular incompetence. Valvular incompetence मतलब valves नलायक है, होते हुए भी उनका कोई फायदा नहीं है. That's the important thing. ठीक है. So now important is most common site. If I talk about बच्चे, if I talk about the most common site, we know that varicose veins will usually, okay, zoom out कर ली, ठीक है. Now most common site for your varicose veins, you have to remember, it will be the lower limbs itself. Okay, the most common site for your varicose veins is definitely going to be your lower limbs itself. Now what is the cause? As I've told you, definitely the valves are incompetent. That means तुम्हारे valves नालायक है, कोई काम के नहीं है, or the valves are absent. Definitely, please remember, there will be valvular incompetence due to at which junctions? Usually one is the saphenofemoral junction, most commonly at the saphenofemoral. तो इसलिए बस saphenofemoral लिखा है, because most commonly the valvular incompetence which is there, it is seen at the saphenofemoral junction. ये जो मैंने बोला था ना, at the level of the femoral region or at the level of the groin, ये जो saphenofemoral junction है, the connection between the great saphenous vein and the femoral vein, that connection पे definitely at that junction the valves are defective. Okay, so therefore definitely most of the times that is the cause. But yeah, definitely it can be valvular incompetence at the level of the saphenopopliteal junction also, or it can be incompetence at the level of the perforators also. Okay, perforators के level पे भी जो valves होते हैं, they are defective. That can also be a problem. Okay, that can also be a problem बच्चे, ठीक है. तो valvular incompetence at the level of the saphenofemoral junction, saphenopopliteal junction, or at the level of the perforators is going to cause a lot of problem, because due to that definitely all the blood, okay, blood flows from deep veins to superficial veins, and that is going to cause all the problem. That will lead to abnormal dilatation and tortuosity of the superficial veins of the leg. Got it, bache? That's the important thing. Now what are the risk factors? Will varicose veins will occur in any patient or what? No. The risk factors will be prolonged, not immobilization, prolonged standing लिखना है यहाँ पे, ठीक है. So it is not immobilization, prolonged standing is a risk factor. Prolonged standing. Why? Because see, if a patient is standing for a very long duration of time, for examples, someone like, not nowadays but पहले के teachers, ठीक है, someone like teachers, someone like surgeons usually. Okay, so definitely surgeons, teachers, or housewives usually. Housewives also stand for a very long duration of time, na? So due to that, definitely the patients who usually stand for a very long duration of time, what is going to happen in them? If they stand for a very long duration of time, the pressure inside the deep veins is going to rise. The pressure inside the deep veins is going to rise. And if they are having this valvular incompetence also, whenever the pressure will rise, all that blood will start going into the superficial veins, and there will be dilatation and formation of the varicosities in the superficial veins. Got it? So that is the problem. So prolonged standing is a very important risk factor. Why? Because it increases the pressure in the deep veins of the leg. First thing. Second is definitely pregnancy. Okay, second. And prolonged standing पे क्यों definitely risk बढ़ता है? When you stand, due to gravity, all the blood mainly flows towards the lower limbs, and definitely if ज़्यादा blood flow is going towards the lower limbs, definitely there will be more blood in the deep veins of the leg, right? That is the reason. Therefore the pressure in the deep veins of the leg will be increased. Second is pregnancy. Now why pregnancy? Because if a patient is pregnant, there's a huge uterus over here. There's a huge uterus over here, and therefore is it going to compress the femoral veins and the other veins? Yes. There's a huge uterus over here, therefore it is going to compress the other veins over here, which are bringing blood from the leg. And as these veins will be compressed, definitely the blood will not be able to come over here, and therefore all that blood will keep on collecting in the deep veins of the leg. And as all the blood keeps on collecting in the deep veins of the leg, therefore pressure in the deep veins is going to increase. Again, increased blood pressure in the deep veins will cause movement into the superficial veins, leading to formation of the varicosities. Okay, that's the important thing. Next is same funda applies for pelvic tumor, because a pelvic tumor also causes the same thing. Okay, it is causing the compression of the veins, bringing blood from the lower limbs, and that is the reason why now blood will keep on collecting in the lower limbs, leading to increased pressure. Even progesterone, why? Because progesterone which is there, bache, this progesterone is progesterone is actually a smooth muscle relaxant, and it causes relaxation of the smooth muscles in the periphery. So all that smooth muscles of the periphery are relaxed, and that is the reason why there will be more blood, okay, which will be pooled inside the periphery itself. ठीक है, more blood pooling will occur inside the periphery, ज़्यादा blood pressure हो जाएगा in the deep veins of the leg, and that is going to cause all the problems. Next is DVT in the patient. Why? Because see, for example, if a patient is having DVT, can you see the pressure over here will be increased due to the blockage? Yes, the pressure inside the deep veins will be increased if there is a thrombus inside the deep veins, and that is again going to cause varicosities in the patient. Okay, the same funda applies. And even genetics, something like a hypercoagulable state can also increase the risk factor. Is it a problem that starts from life with late symptoms? Matlab, it is not a congenital problem, bache. Yeah, valvular incompetence is congenital, but the patient will have symptoms later on in the life. बचपन से तो symptoms नहीं होंगे. There should be risk factors along with the valvular incompetence which is going to cause the condition. ठीक है? That's the important thing. Now what will be the complaints of the patient? The clinical features of the patient will be a aching discomfort in the calf or the heel region. There will be a constant dull ache. Okay, हमेशा दर्द थोड़ा थोड़ा बोलते हैं ना. Always there will be a constant dull ache in the patient's leg. Always a patient की leg में हमेशा दर्द रहेगा, either in the calf region or in the heel region. ठीक है? So please remember, aching discomfort which will be there in the calf or the heel region will be there. Along with that, you will be able to see the dilated veins. Okay, can you see? This is what is called as varicosities. If you are able to appreciate this, these dilated tortuous veins which are clearly visible superficially, these are what are called as varicosities. These are the varicose veins. Got it? So definitely here the patient's complaint will be a constant ache, dull ache inside the calf or the heel, and the patient will be having this dilated veins which are superficially visible. Okay? That is an important thing. On examination, what should be done? So on examination, we can do a 2 test. So understand how these tests are done usually. Okay, सबसे पहले ask your patient to lie down. Patient को सुलाओ अपने. Then you have to raise the leg of the patient. As you ask the patient to raise the leg, then you have to press all his leg. Then you have to press all his leg, and you have to empty his leg. जितना भी blood उसके पाँव में जमा है, empty all that blood. ठीक है? So you have to press the leg of the patient for some time, and then you have to empty his leg. Once you have emptied his leg, then you have to tie a tourniquet over here. ठीक है, एक tourniquet बांध देना है यहाँ पे तुम्हें. Tourniquet is nothing but a tight ligature, something like thing. ठीक है? So usually you are going to apply a tourniquet over here at the level of the thigh. At the level of the thigh, you are going to tie a tourniquet. Okay, and now you will ask the patient to stand up. Now you will ask the patient to stand up, and as soon as the patient stands up, I am going to remove the tourniquet. As soon as the patient stands up, I am going to remove the tourniquet. As I remove the tourniquet, बच्चे, I will be able to see that the blood fills up in the superficial veins really fast. जो blood है ना, वो superficial veins में बहुत तेजी से भरता है, and immediately I will be able to see those varicosities. Now when I was emptying the blood, definitely all the blood went. Therefore, the varicosities disappeared. They were not visible clearly. But as soon as I asked the patient to stand and I opened up the tourniquet, all that blood flowed very fast from the deep to the superficial veins, and therefore I was able to see all that varicosities which appeared. Okay? So this is called as the tourniquet test, and this is usually done to check the valvular incompetence at the level of the junctions. Okay? ये क्या बता रहा है मुझे? That ये जो तुम्हारे valves है, ये absent है या defective है at the level of the junction. मतलब either at the saphenofemoral junction or at the level of saphenopopliteal junction. Why? Because if the blood is filling so rapidly, that means definitely there is not a problem at the level of perforata, because perforators are very small. These are junctions which are defective. There is some problem at the level of junction. क्यों? Because of junction there is rapid flow. Alright? If there is problem at the level of junction, then there will be rapid filling. अगर perforators पे है तो धीरे धीरे filling होगा. That test also I will talk about now. what do we do for checking problem at the level of perforators? Now again ask your patient to lie down, सीधा सोया, then you are going to raise his leg, वापस से उसका पैर उठाओ, and then again try to empty his leg. If you are going to empty his leg, completely empty his leg, then you are going to tie tourniquet again. You are going to tie tourniquet, and now you ask the patient to stand up. Once your patient stands up, you are not going to remove the tourniquet now. तुम tourniquet नहीं खोल रहे हो. You just observe. Now definitely, even if the tourniquet is not released, मतलब the junctions are not open, बराबर, junctions are still closed because you have applied a tourniquet. But you can see still there is filling which is occurring. हाँ धीरे धीरे होती है. Definitely there is a gradual filling now which is occurring, and definitely the varicosities will again start to appear, but slowly. In first test they were appearing rapidly, but here they will appear slowly, gradually they will appear, but they will start to appear. Now the junctions are blocked. Why the patient is having problem? The patient is having problem because the problem is not at the level of the junction. The problem is at the level of the perforators itself. ठीक है? This is what is called as the Fagan's test. समझ गए? अब भले भूल जाओ, does not matter. More important is to remember the name of the test. Okay? More important is to remember the name of the test. Once you have understood it, that's more important for me. Valvular incompetence, बच्चे, for that the test that we did was known as the tourniquet test. Okay? It was known as the tourniquet test. Whereas the perforator incompetence के लिए the test that we did was known as the Fagan's test. Okay, remember the name of the test. ठीक है, दोनों टेस्ट के नाम कम से कम याद रख लो. Valve incompetence देखने के लिए at the level of junction. Okay, valvular incompetence at the level of junction. Valvular incompetence at the level of junction, definitely we do a test known as the tourniquet test, and to check the perforator incompetence we do a test known as the Fagan's test. We do a test known as the Fagan's test. No issues with this, anybody? Hopefully. Okay. Now, important is what will be the symptoms of the patient. First, I have told you constant dull ache will be there along with these dilated veins. But important is these dilated veins will have various types of appearance. ठीक है, अलग-अलग type का appearance होगा. If I talk about the clinical classification of the varicose veins, there will be various classification. So now, when the veins start to dilate, if they are less than 1 millimeter dilated, बच्चे, these small dilated veins which appear like thread, धागे जैसी दिख रही है ना, so these small dilated veins which appear like threads usually, these are called as the thread veins, or we can call them telangiectasia. These small dilated veins which are less than 1 millimeter dilated, these are called as thread veins or telangiectasia. When they are 1 to 3 millimeter dilated, these are called as reticular veins. When they are 1 to 3 millimeter dilated, they are called as reticular veins. Then, if they are more than 3 mm dilated, just a minute. If they are more than 3 mm dilated, बच्चों, you have to remember definitely these will be called as your varicose veins. Okay, they are called as varicose veins, and definitely can you see varicose veins when the tortuosity is seen. The veins are more dilated and the tortuosity also starts appearing. टेढ़े मेढ़े दिखने लगते हैं वो, ठीक है. Then definitely as the pressure is increasing over here, definitely if the pressure in the superficial vein starts increasing, it will start to push out the blood. Or matlab it will start to push out the fluid. And if the fluid is kicked out of the vessel, it will start collecting between the cells. Collection of fluid between cells is known as edema. Therefore, the patient is going to have edema over here. Then there will be development of edema. Then as the blood stays over there for a very long duration of time, therefore the patient will start developing pigmentation or eczema. Yes, the patient starts developing pigmentation or eczema. Then the patient will even have healed ulcer, or the patient will have an active venous ulcer as well. ठीक है? So that is the clinical classification that we do usually. तो सबसे पहले start होता है thread veins or telangiectasia less than 1 millimeter, then reticular veins 1 to 3 millimeter, more than 3 millimeter varicose veins, and then edema, pigmentation or eczema, that is skin changes, and definitely there will be formation of an ulcer later on. ठीक है? Important is you can see this classical picture. What is seen over here? Can you see the small veins at the level of the ankle are dilated? Yes, and these dilated veins are actually forming a fan-like pattern. Fan-like pattern बना रहे हैं ना? This is called as the classical malleolar flare. Are you able to see this? Just a minute, I'll use another pen. This is classically बच्चे called as a malleolar flare. इसको malleolar flare बोलते हो, fan-like pattern of telangiectasia or fan-like pattern of the dilated veins, or we can even call it as coronaphlebectasia. Coronaphlebectasia. Previous year image-based question it has been in NEET PG, so please be aware of this. It is called as बस डायग्नोसिस फॉर डायग्नोसिस पूछा था. इट इज नथिंग बट फैन शेप पैटर्न ऑफ द डायलेटेड वेन्स नोन एज द मैल्युलर फेयर और इट इज नोन एज कोरोना फ्लेबिक्टेशिया. इट इज वन एंड द सेम थिंग, फैन पैटर्न. ठीक है, तो फैन पैटर्न जैसा telangiectasia which is there, it is known as corona flabectacia or the mallular flare. ठीक है, that is important. Next, definitely this is also previous year image based question. What is seen over here? You can see the dilated vessels on the sides, but in the center you are able to see a hypopigmented, that is a whitish area. So hypopigmented or a depigmented area in the center surrounded by telangiectasia or dilated veins in the sides. This is called as atrophy blanche. This is what is known as the atrophy blanche बच्चे. This is what is classically called as the atrophy blanche. ठीक है, this is atrophy blanche. And the last one, the last feature which is going to appear in the patient is going to be this one. Due to chronic varicose veins in the patients are going to develop this kind of a feature. What is this? This is the classical, you have to remember, this is the classical lipodermatosclerosis. Yes, this is the classical image based question of FMG now. Twice asked that too in the examination. This is a classical feature of lipodermatosclerosis. Okay, easiest one actually. So if I talk about lipodermatosclerosis, what is seen over here? So important is mallular flare can be seen usually in the class 1 itself. ठीक है, it is usually seen in the class 1 itself. But अगर पूरा का पूरा corona flabectacia जैसा हो गया, बड़ा सा fan shape pattern हो गया, then it is class 4C. I'll talk about that, don't worry about that. ठीक है, C आप classification बोलूंगा मैं भी. डर्मेटोस्क्लेरोसिस की बात करें अगर बच्चों में, मैं डर्मेटोस्क्लेरोसिस की अगर मैं बात करूं, definitely you have to remember in this condition what is going to happen. The patient will have fat loss over here. The patient is going to have fat loss in the leg. Second, the patient will have muscle contracture. The patient will have muscle contracture, and as there is fat loss, there is muscle contracture, there is a woody hard feel. Okay, when I palpate the leg of this patient, okay, at this area I'll get a woody hard texture. एकदम लकड़ी जैसा कड़क हो जाएगा ये पैर यहाँ पे. There will be a woody hard texture. Okay, and definitely there will be pigmentation. As you can see, there is a pigmentation which is seen. All of these features: fat loss, muscle contracture, woody hard texture, and pigmentation. And classical appearance. Anybody? कौन सा appearance दिख रहा है ये? Can anybody tell me which appearance of leg is seen in the patient? Which appearance of leg is seen in the patient? Can you see something like this? What is this appearance? Very good. This is the classical inverted champagne bottle appearance. Okay, this is the classical inverted champagne bottle appearance. Inverted champagne bottle appearance is classically seen in the patient. Okay, so lipodermatosclerosis classically leads to a inverted champagne bottle appearance. Okay, it leads to a classical inverted champagne bottle appearance. Okay, so that's the important thing you have to remember. This is a classical picture of your lipodermatosclerosis, classical feature of your lipodermatosclerosis. Now the classification that we use for varicose veins, बच्चों, this has been asked. बस इतना ही पूछा गया that CAP classification is used for which condition. So you have to remember CAP classification which is there, it is used for varicose veins, and you have to understand the full form also. You have to remember the full form also. What does the C, what does the E, A and P stands for? ठीक है? So if I talk about the CAP classification of the venous disorders, if I talk about the CAP classification of the venous disorders, you have to understand, बच्चे, you have to understand. Now, C stands for what? The classification which is based, okay, the classification which is based on clinical manifestation, based on the signs and symptoms. Based on the signs and the symptoms of the patient, if you are going to classify the varicose veins, that is what is called as a clinical classification, right? Next is E stands for etiological classification. Based on the cause, what is actually the cause of the patient's varicose veins? Based on the cause, definitely if you are going to classify it, it will be called as a etiological classification. And next, important, A stands for anatomy. Okay, that means which veins are actually involved, which veins are involved, where actually the patient is having varicosities. Okay, depending on that, if you are going to classify the varicose veins, that is called as an anatomical classification. That is what is an anatomical classification. And last one, P stands for pathophysiology. That means what is the cause actually for the varicose veins, किस वजह से वो varicose veins develop हो गए. So due to that, if you are going to do a pathophysiological classification, then definitely that will be called as a P stands for the pathophysiological classification. Important is इसमें बस clinical classification is important on which questions have been asked to you. बाकी तुम भूल जाओ, does not matter. Okay, but this at least remember that What is the full form of CM? C for clinical classification, E for etiological classification, A for anatomical, and P for pathophysiological classification. ये पता होना चाहिए, ठीक है? That has been asked. Important is you have to remember the whole clinical classification, बच्चे, because questions have been asked on clinical classification in your exam, that too thrice from August 2020 onwards. ठीक है? अब 3 बार अगर क्वेश्चन आ चुका है तो डेफिनेटली दे आर वेरी सीरियस अबाउट दिस, सो इट्स बेटर इजी है. द वन दैट वी सॉ ना उसी फैशन में क्लिनिकल क्लासिफिकेशन है. ओके, सो C1 इज व्हाट? telangiectasia or reticular veins. ठीक है? If the patient is having telangiectasia, that means less than 1 millimeter का dilated veins और reticular veins 1 to 3 millimeter का dilated veins, that is what is called as C1. ठीक है? C2 is what? C2 is nothing but varicose veins. That means more than 3 millimeter का dilated veins. More than 3 millimeter का dilated vein, that is varicose veins, C2. Okay, C2R. If they add the small r over here ना, that R stands for recurrent. मतलब बार बार हो रहे patient में. ठीक है? So C2R means nothing but R stands for recurrent. That you have to remember. Anywhere if they add R, R stands for recurrent. ठीक है? So that is important. Then C3 is for edema. As I've told you, the pressure increases, the fluid is kicked out of the vessel, it keeps on collecting between the cells, and that leads to formation of edema. C4 now. C4 is actually divided into 3 types. C4 which is there. C4A is known as pigmentation. If there is pigmentation or eczema, that is C4A. Okay, pigmentation or eczema is C4A. Lipodermatosclerosis, the one with that we saw, the inverted champagne bottle appearance. That inverted champagne bottle appearance or lipodermatosclerosis is C4B, and this has been a recent question of your exam. Okay, C4B is lipodermatosclerosis. उन्होंने इमेज देके ये नहीं पूछा डायग्नोसिस क्या था, उन्होंने इमेज देके स्टेजिंग पूछी थी. प्लीज रिमेंबर दैट. ओके, सो lipodermatosclerosis is C4B बच्चे, and C stands for C. That means in NEET PG there was a previous year question, corona phlebitis की इमेज दी हुई थी, the one that we saw, fan shape pattern, that is C4C. ठीक है? corona phlebitis is what is C4C usually. ठीक है? C5 is nothing but a healed venous ulcer, and C6 is actually an active venous ulcer. C6 is nothing but an active venous ulcer. तो जल्दी से once again we'll revise. C1 मतलब telangiectasia और reticular veins, C2 मतलब varicose veins, C3 मतलब edema, C4A pigmentation और eczema, C4B lipodermatosclerosis, C4C corona phlebitis, C5 healed venous ulcer, and C6 active venous ulcer. Got it? So that's how you have to remember the classification. Done. Okay. Now next important, if I talk about the investigation of choice, again I've told you for varicose veins also, these are superficial veins, so easily okay, chalo then. Now definitely if I talk about the investigation of choice definitely बच्चे, here also the patient is going to have what? Duplex scan itself. ठीक है? So investigation of choice will always be the duplex scan here also, and when we do a duplex scan of this patient, you have to remember, okay, on the duplex scan what is going to be seen? See, normally this is nothing but your femoral vein, definitely. Okay, this is nothing but your femoral vein, this is your femoral artery out here. ठीक है? And this is the saphenofemoral junction out here. But ये जो saphenofemoral junction है, it is not usually seen because it is collapsed. Normally छोटा होता है, पतला होता है. But now definitely as there is more blood flow via the saphenofemoral junction. Can you see the saphenofemoral junction appears to be dilated? Yes, ये जो saphenofemoral junction है बच्चे, that appears to be dilated, and therefore you can see a classical Mickey Mouse sign. ठीक है? So this is the classical Mickey Mouse sign which is usually seen in a duplex scan. So Mickey Mouse sign on a duplex scan is a classical feature in a case of varicose veins. It is due to actually incompetence at the level of the saphenofemoral junction. The Mickey Mouse sign is classically seen on a duplex scan at the saphenofemoral junction due to the incompetence or due to varicose veins. ठीक है? So that is the classical picture. कोई दिक्कत नहीं है इसमें. So once we have done the diagnosis of your varicose veins, once we have done the diagnosis of our varicose veins, let's talk about the treatment now. On the duplex or the color Doppler, you will be able to see the blood flow from deep veins to the superficial veins of the leg. Okay, that is how you confirm the diagnosis. Now, if I talk about the treatment, if the patient comes to us in early stages, that means telangiectasias or reticular veins, ऐसे कई condition में आता है. If the patient comes to us in the early stages of itself, then the management is going to be lifestyle modifications. Then the management has to be lifestyle modification. If I talk about lifestyle modifications, क्या करेंगे हम patient में? Definitely, you have to remember one of the risk factors is definitely obesity. So always ask the patient for weight reduction. मैंने क्या बोला? Definitely anything which is blocking the vessels, anything which is blocking the vessels to bring blood back to the IVC, okay, that is going to cause increased blood pressure in the deep veins, and that is going to cause varicose veins. So obesity can also be one of the risk factors, right? If there is a lot of obesity over here, a lot of fat, that is also going to cause problems. So definitely obesity is one of the risk factors. That is the reason the first advice that you will give the patient if he is obese or she is obese is weight reduction. Usually seen in females commonly, वैसे तो common housewives की वजह से in India at least, ठीक है? Next important, you have to remember, after weight reduction, you will also ask the patient to avoid prolonged standing, because if the patient keeps on standing for a prolonged time, then definitely it is going to cause problem. Okay, so avoid prolonged standing. Okay, if she is a housewife, we'll ask her to definitely do her household chores or works by sitting down. Okay, that will be better. And if he is a surgeon, definitely he can use a chair. If not, definitely while he's performing a surgery or any other patient, while they are doing their work, they can just wear the elastic compression stockings. Okay, yes, they can use the elastic compression stockings. So you might be seeing a lot of surgeons who are using elastic compression stockings. Okay, they usually use the elastic compression stockings to avoid varicose veins. Okay, because they have been standing in the OT for longer durations, like almost straight 7 hours, 8 hours. Okay, so even more than that at times. So that is the reason usually you have to remember elastic compression stockings are generally used. Okay, so that is the important thing. These are the three things that we do in lifestyle modifications in a patient of varicose veins in the early stages. Late, if I talk about, if the patient presents to us in the late stages, then definitely we have to go for a surgical management. If the patient presents to us in the late stages, we have to go for a surgical management in the patient. And if I talk about the surgical management, then the best one which is there, available now, it is definitely, okay, either a EVLT. What is the EVLT? Endovenous laser therapy, or it is a RFA. What is the RFA? Radio frequency ablation. Okay, either it is a endovenous laser therapy or it is a radio frequency ablation. I'll talk about them. First, I'll talk about the conventional surgeries used for varicose veins. Now, first thing is great saphenous vein and the saphenofemoral junction incompetence. Great saphenous vein and saphenofemoral junction incompetence. If there is problem at the level of the saphenofemoral junction, जो तुम्हारा saphenofemoral junction है at the level of the femur, at the level of the upper thigh, that is problematic. उसमें कोई ना कोई दिक्कत है, ठीक है? So definitely, if that is problematic, if the valves are defective over there at the saphenofemoral junction, you are going to go for an operation which is known as Trendelenburg operation. You are going to go for an operation known as Trendelenburg operation. Okay. Now important is, in Trendelenburg operation, बच्चे definitely you have to go for the Trendelenburg operation. अब उसमें क्या किया जाता है? Here, first of all, for example, this is my femoral vein. Just a minute. This is my femoral vein, and this is my great saphenous vein out here. This is my great saphenous vein, and this is the junction definitely. Okay. Yeah. Just a minute. Hopefully now it's visible, बच्चों. Now it's visible, no issues in that. Now it is not causing any problem, right? Okay, chalo. See, now this is the femoral vein, this is the great saphenous vein, and this is the junction, for example. Okay, femoral and great saphenous vein का ये junction है. Now as you can see, there are no valves which are present. There are no valves which are present at the junction, the saphenofemoral junction. At the saphenofemoral junction, there are no valves which are present. Okay, that is causing all the problem. Now what are we going to do? We are actually going to do a flush ligation. We are actually going to go for a flush ligation of this saphenofemoral junction. What do I mean by flush ligation? This is what is called as flush ligation. Flush का मतलब होता है एकदम onto the surface. Okay, exactly onto the surface. Definitely we are going to ligate it. Reason is, if we ligate it somewhere over here, can you see the stump is left behind? That stump can also have problems. Okay, that stump can also rupture. That is the better part. Therefore, we don't go for another type of ligation. We directly go for a flush ligation. We try to see, important is, if the patient is having problems at the level of the saphenofemoral junction, that means the valves are absent at the level of the saphenofemoral junction, between the junction of femoral vein and the great saphenous vein, then in this condition we have to do a ligation of the saphenofemoral junction. ये सब मानते हो? We have to close that saphenofemoral junction, right? So that the blood should not go from the deep veins to the superficial veins, right? So for that we have to do a ligation. We have to do a flush ligation, okay, because we have to ligate the junction as close as possible to the vein, because if we leave a stump, there will be a risk of rupture of that stump that we don't want, right? So that is the important thing. Here we have to go for flush ligation. Here we go for actually a flush ligation of the saphenofemoral junction, and we also remove the great saphenous vein. Yes, even we can do a stripping of the great saphenous vein till the knee. Here we do a stripping of great saphenous vein till the knee. Please remember, from here we are going to remove, or we are going to strip off the great saphenous vein, but only till the knee. Reason is, why not below the knee? Because please remember, अगर तुमने नी के नीचे से great saphenous vein हटा दी, reason is, below the knee this great saphenous vein is very closely associated with the saphenous nerve as well. Okay, below the knee this great saphenous vein is very closely associated with the saphenous nerve. So if you strip off the great saphenous vein below the knee, it is going to cause injury to the saphenous nerve as well, and that you don't want. Okay, so that is the important thing, बच्चों. Please remember, that is important thing that you have to remember. ठीक है, तो याद रख लो, if there is a problem at the saphenofemoral junction, if there is a saphenofemoral junction incompetence, you are going to go for a Trendelenburg operation where you do a flush ligation of the saphenofemoral junction. That means you close the saphenofemoral junction and you strip off the great saphenous vein till the knee. Why not below the knee? Because below the knee it is closely associated with the nerve, and if you try to strip off below the nerve, below the knee, it is going to cause injury to the nerve as well. ठीक है? Next important is, if there is problem in the short saphenous vein or at the saphenopopliteal junction incompetence. If there is problem at the saphenopopliteal junction now, here the surgery does not have a classical name. Here you just go for flush ligation of saphenopopliteal junction. Here you just go for flush ligation of saphenopopliteal junction. याद रखना, we don't strip off the short saphenous vein also. Reason is, short saphenous vein below the knee, it is always present below the knee. See, जो ग्रेट सैफिनस वेन होती है उसको ग्रेट सैफिनस वेन इसीलिए बोला जाता है बिकॉज इट स्टार्ट्स ऑन द मीडियल एस्पेक्ट ऑफ द it starts from the medial aspect of the leg and it comes till over here. It is going to come till over here, okay, till the femoral region. But जो short saphenous vein होती है बच्चे, it starts on the lateral part of the ankle. That short saphenous vein starts from the lateral part of the ankle and it is going to end at the level of the knee. It is going to end at the level of the knee. Important is, you are not going to remove the short saphenous vein, because if you remove the short saphenous vein बच्चे, then please remember what is going to happen is there will be risk of injury to the sural nerve. There will be risk of injury to the sural nerve as well. Okay, so these surgeries are not commonly done nowadays. Okay, these surgeries usually are resource limited settings में, these are the common ones, but nowadays as lasers are available, so better one are lasers usually. ठीक है, better one are always lasers nowadays. ठीक है, ठीक है, तो प्लीज रिमेंबर Trendelenburg operation or flush ligation of the short saphenopopliteal junction can be done in the patient. ठीक है, Next important is if there is a perforator incompetence. If there is a perforator incompetence, nowadays the surgery that we do, पहले कौन सी surgery करते थे याद रखना. See, perforators अगर incompetent है, perforators तो बहुत सारे, there are many perforators. I've told you 100 to 150, but the important ones also I've told you Hunterian, Boyd, Dodd and Crockett. Important is what we used to do first of all on the leg. We used to give multiple incisions. And then we used to ligate each perforator. Then we used to ligate each and every perforator which was there. Okay, that is important. But now then we thought कि यार इतने सारे incisions क्यों देने? Why we need to give so many incisions? So we used to make a single incision. We used to create a tunnel. Okay, हम एक tunnel create करते थे. And then we used to insert endoscope out there. Endoscope जैसे ही डालोगे definitely you will see with the help of the camera the whole tunnel. Okay, so with the help of that endoscope definitely see. For example, I've created single incision. I've inserted my endoscope over here. I'm able to see the whole tunnel, and there are a lot of perforators out here. So what I'll do from the single tunnel, definitely I'll start ligating each and every perforator. Okay, from the single tunnel I'll keep on ligating the perforators. That is what is done, bacho. So usually this surgery, when actually I only make a single incision and I insert an endoscope with the help of which I can ligate multiple perforator. This is a preferred surgery for perforator incompetence. This is known as the SEPS, subfacial endoscopic perforator surgery. ठीक है, subfacial endoscopic perforator surgery. तो perforator के लिए, for perforator incompetence, you have to remember the surgery that is preferred nowadays is nothing but the subfacial endoscopic perforator surgery. It is a subfacial endoscopic perforator surgery, also known as SEPS. It is also known as SEPS. ठीक है, that's important. If that is not an option, the previous surgery जो मैंने बोला multiple incisions देके करते थे, in that surgery you used to do ligation of the Dodd and the Crockett ones. So that was called as the Dodd and the Crockett surgery. Okay, better one is always SEPS because with a single incision you are going to ligate a lot of perforators. But if that is not an option, you can go for the previous surgery which was used, and that is known as the Dodd and the Crockett surgery, where multiple incisions were given for ligation of these Dodd and the Crockett perforators. Got it? That's important. But nowadays, usually as I've told you, the new modalities which have come. Okay, one of the new modalities, अब तो वो भी पुरानी होगी, but that is nothing else but sclerotherapy. Yes, to block these junctions or to block these incompetent perforators, we used to use a sclerosing agent. और वो sclerosing agent क्या करता था? इन perforators में sclerosis करवा देता था या इन junctions में sclerosis करवा देता था. As it is used to cause fibrosis or sclerosis at the junctions of perforators, these perforators used to get blocked. ठीक है? So that was called as sclerotherapy. Important is, if I talk about the sclerotherapy, just remember sclerotherapy is still used commonly also. Sclerotherapy में बच्चों, the sclerosing agent which is used, the most common sclerosing agent which is used has been asked in the examination as well. The most common sclerosing agent, it is 3% sodium tetradecyl sulfate. It is 3% sodium tetradecyl sulfate. That is the most common sclerosing agent that we use. Reason is बच्चे, ये क्यों बता रहा हूँ? Because this sclerotherapy is going to come a lot of times further as well. Yes, it is going to come in esophageal varices also. It is going to come in hemorrhoids also. ठीक है? So therefore you have to understand that sclerotherapy which is there, it is nothing but blocking those perforators or blocking those junctions with the help of sclerosis or fibrosis by injecting some substance which are going to cause fibrosis. And the most common sclerosing agent that we use is a 3% sodium tetradecyl sulfate. Okay? That's the important thing. Now the new modalities which are there, even newer than sclerotherapy, they are preferred nowadays. One is called as EVLT, that is nothing but endovenous laser therapy or endovascular laser therapy. Okay, one is known as endovenous or endovascular laser therapy. Okay, EVLT. And second is radio frequency ablation, RFA. Important is both of these surgeries will have same efficacy. दोनों की efficacy same है. Both of them are having same results. That is the reason both of them can be preferred. None out of them is definitely the surgery of choice. ऐसा कुछ नहीं है कि ये ज़्यादा अच्छी है वो ज़्यादा अच्छी है. Both of them have shown the same results, and that is the reason it depends on the availability of the resources, that whether you are going for a EVLT, that is endovenous laser therapy, or you are going for a RFA, that is radio frequency ablation. Got it? So the surgery of choice nowadays, अगर पूछे बच्चे, the surgery of choice nowadays, if they ask you, definitely the surgery of choice for varicose veins with least amount of complications are to be EVLT or RFA. The surgery of choice nowadays have to be EVLT, endovenous laser treatment, or RFA, radio frequency ablation. Okay, so please remember. अरे please the same one Trendelenburg में जो किया वही है definitely. So please remember, if for example this is your deep vein known as your popliteal vein, ठीक है, and this is your superficial vein known as the short saphenous vein. Okay, important is the junction which is over here, it is not having any kind of perforator. That means the junction over here, it is not having any kind of valve. That means this junction which is there, it is incompetent. And ऐसा अगर incompetent junction होगा बच्चे, तो definitely there will be formation of varicose veins. So we have to block this junction, and to block this junction we have to ligate. We have to actually ligate this junction. So we will do flush ligation of this sapheno-popliteal junction, and that is what is done in cases of the sapheno-popliteal junction incompetence. Okay. I was not writing, I was just drawing. I'll show it to you just a minute. हो गया शायद. Hopefully now it's fine. Hopefully now it's fine. Okay, great. So this is what I was explaining. Popliteal junction between the popliteal and the short saphenous vein. अगर इसमें incompetence है, you have to ligate this one. Okay, and that is what is known. That is what is done in a case of sapheno-popliteal junction incompetence. Okay, so that is important to be remembered. I'll start GIT at least today, because otherwise it will be difficult to complete GIT in time. Okay, at least I'll start with something of esophagus. All of you are quite aware of esophagus. Easy है वो, थोड़ा सा पूरा नहीं करेंगे, obviously I know. EVLT full form, endovenous laser therapy. We are going to enter inside the laser. We are going to enter inside the veins of the patient, and then with the help of a laser, we are actually going to burn out, or we are actually going to block these junctions or these perforators. Okay, with the help of the lasers, we are actually going to block these perforators or these junctions, incompetent ones. Got it? That's the important thing. Or in radio frequency ablation, we are going to block these perforators or these junctions with the help of radio frequency waves. Okay, that's the important thing. Okay. We are going to do the same thing, but with the help of different techniques. That's the reason why the surgeries are different. Last one, very short topic, and that is lymphs. Lymph mein lymphedema is only we are going to study, but lymphedema was never asked in your examination, but it has been asked very commonly nowadays. So please be aware of this fact now. So if I talk about lymphedema, edema is nothing but collection of fluid. But which fluid, bachche? Lymph. So lymphedema is nothing but accumulation of interstitial fluid. Interstitial fluid is nothing but lymph over here. तो उसको lymph भी बोल सकते हो, ठीक है. तो accumulation of lymph or accumulation of interstitial fluid, collection of interstitial fluid is what is called as lymphedema. Important is it more commonly occurs in the lower limbs as compared to the upper limbs. It more commonly occurs in the lower limbs as compared to the upper limbs, just like any other condition we have seen till now. There are two types of lymphedema. Either it can be a primary lymphedema or a secondary lymphedema. Now primary lymphedema matlab there is some problem in the lymphatic channels itself. Yes, due to some defect in the lymphatic channel, there is collection of lymph. Now there is problem in the lymphatic channel itself. Therefore, this is called as primary. Due to problem in the lymphatic channel, there is collection of lymph. That is what is primary. No other condition is responsible for it. So due to hypoplasia, what is hypoplasia? Underdevelopment. Hypo ka matlab under, plasia ka matlab development. So hypoplasia or underdevelopment of the lymphatic channels. Okay, due to hypoplasia of the lymphatic channels, bachche, there is collection of lymph at a specific site only, and that is what is causing a primary lymphedema. Secondary lymphedema ka, there can be multiple causes. Okay, secondary lymphedema can be due to multiple causes. It can be due to a surgery, it can be due to multiple infections, it can be due to a cancer, multiple causes. But the most common cause is what? The most common cause is filariasis. The most common cause is filariasis. I hope all of you are quite aware there are two types of filariasis you might have studied in PSM or micro. One is called as the Bancroftian filariasis caused by Wuchereria bancrofti, and second is the Bruggian filariasis caused by Brugia malai. Important for us is the Bancroftian filariasis caused by Wuchereria bancrofti. Reason is definitely because that Bancroftian filariasis is also known as lymphatic filariasis, because it is going to cause problem at the level of the lymphatic channels itself. Okay? So that lymphatic filariasis or that Bancroftian filariasis definitely, okay, that Bancroftian filariasis which is caused by Wuchereria bancrofti, that is the basic one which is going to cause a lot of problems. No issues with this, anybody? And definitely other causes can be a lot of infections. It can be a lot of surgeries as well which will be responsible. Okay? You have to remember upper limb में अगर होता है, already I have told you, anybody can recall upper limb में lymphedema का most common cause कौन सी surgery थी बच्चे? Most common cause of lymphedema in the upper limb. In lower limb, the most common cause is definitely filariasis. In lower limb, the most common cause is definitely filariasis, which if it can further progress, it can cause even this kind of deformity in the leg, and this is called as elephantiasis. We know filariasis initially will only cause lymphedema. Filariasis initially will only cause lymphedema, but then further it is going to cause what? Elephantiasis, when it leads to a lot of deformities as well. Okay? So that's the important thing. Very good. Yes, MRM. Very good, all of you. The most common cause of upper limb lymphedema will be MRM. Most common cause of upper limb lymphedema will be MRM. Very good. Modified radical mastectomy. Yes. Next important, if I talk about investigation. So if I talk about the investigations for lymphedema, you have to remember the investigation that I can do is known as plethysmography. Okay. It can be a plethysmography, which is the investigation, but gold standard which is there. Plethysmography is an investigation which will tell me about the flow and the collection of lymph. ठीक है, जैसे मुझे Doppler, it is telling about the flow of the blood. Now plethysmography is going to tell me about the flow of the lymph usually. Gold standard which is there, you have to understand this gold standard investigation will be a lymphangiography. What better than actually seeing the lymph vessels itself? जैसे we were seeing the blood vessels with angiography, we are going to see the lymph vessels with lymphangiography. The lymphangiography will be the gold standard investigation. Treatment is what, बच्चे? Treatment is nothing but manual drainage. Now what is manual drainage? अपन खुद से कैसे drainage करेंगे? By massage. ठीक है? So you have to do a lot of massage and physiotherapy with the help of that manual drain, with the help of that massages and physiotherapy. Definitely you are going to reduce this lymphedema, or you are going to reduce the swelling. ठीक है? So that has to be done. So manual drainage and compression stockings can be used. Manual drainage and compression stockings can be used definitely for reducing the lymphedema. Manual drainage के लिए मैंने बता दिया already. You can either use a massage usually. You can go for a massage. ठीक है? That is important. Manual drainage and compression stockings. Manual drainage is done by massage. Now, can anybody recall that I've told you, if a patient is having a long-standing lymphedema, if a patient has a long-standing lymphedema for almost 8 to 10 years, okay, the patient can develop definitely a cancer. The patient can develop a cancer from the lymph vessels, and that cancer is known as lymphangiosarcoma. The patient can develop a cancer from the lymphatic vessel known as lymphangiosarcoma. As you can see, this kind of appearance. ये previous year image based question है बच्चे. Okay, lymphangiosarcoma can develop in the patient. And what is this syndrome called as? Anybody can recall? Breast में मैंने बताया था after MRM. Without turning the pages, answer please. Can anybody recall it? You are not doing any test. Just if you can, just tell me if you are able to recall. What is the secondary malignancy or secondary cancer which develops after 8 to 10 years of lymphedema known as lymphangiosarcoma? क्या बोल 10 मिनट का ब्रेक दे रहा हूँ इनको। चलो बच्चों, होपफुली आई एम ऑडिबल, नो इश्यूज विद ऑडियो विजुअल्स. थोड़ा सा और करेंगे, ठीक है, एंड देन विल कॉल अप द सेशन. ठीक है, नो इश्यूज विद दिस. A lot of things you might be knowing from here already. Anatomy and physio में हो चुकी होगी. We'll just brush it up and do some important topics. ठीक है, चलो. Now if I talk about the first part of your GIT, basically the GIT usually it starts from the oral cavity. All of us are quite aware about that. Okay, the oral cavity, that is your teeth, the buccal mucosa, the gingiva, the tongue, the palate. Then definitely this oral cavity which is further. Okay, खाना कैसे आगे बढ़ेगा? Definitely from oral cavity there will be a muscular pipe which is there, and that muscular pipe is nothing else but your esophagus. Okay, that esophagus will further continue and it will go into a bag. What is that bag? Stomach. Okay, from stomach definitely it will continue further into your small intestine. Small intestine is made up of 3 parts. Okay, सबसे पहला होता है duodenum, the second one is jejunum, and the third one is ileum. So duodenum, jejunum, ileum. Then from there the large intestine is going to start. So the small intestine and large intestine का जो junction होता है, it is between the ileum and the cecum. Therefore it is also called as ileocecal junction. Okay, then definitely there will be the first part of your large intestine, also known as colon, that is called as cecum. जो तो पहला part होता है उसको क्या बोलेंगे? Cecum. From there definitely there will be the ascending colon. See over here we have the cecum. Okay, so definitely from here we are going to have the ascending colon. Then we are having the transverse colon. Then definitely we'll have the descending colon. Here we are going to have our sigmoid colon. Here we are going to have our sigmoid colon. Then there will be the rectum and finally the anal canal. Right? Important is first we are going to talk about the esophagus now. If I talk about the esophagus, bache, you have to remember esophagus, as I've told you, it is actually a muscular tube. And what is the length of the esophagus? The length of the esophagus is going to be 25 centimeters. Okay, so the length of the esophagus is going to be 25 centimeters. Important is you have to remember that this esophagus which is there, it starts at which level? तो याद रखना है बच्चे, सबसे पहले as I've told you oral cavity होगी, फिर there will be pharynx and then there will be starting of the esophagus. So usually this pharynx which is there बच्चों, this pharynx which is there, this meets with the esophagus at which junction? This junction should be called as pharyngo-esophageal junction, जहाँ पे pharynx खत्म होता है और esophagus start होता है. Okay, the place where pharynx ends and the esophagus starts is what is called as pharyngo-esophageal junction, or we can call it as the cricopharyngeal sphincter also. Why? So you have to remember, because this pharyngo-esophageal junction which is there, this pharyngo-esophageal junction which is there, it is made up of a muscle known as the cricopharyngeus muscle, and that is the reason why here we can call this area as well as the cricopharyngeal sphincter. What is a sphincter? Sphincter is the one when it constricts, it is going to close the opening. स्पिंक्टर किसको बोला जाता है? जब वो कंस्ट्रिक्ट करता है तो ओपनिंग को क्लोज करता है, ऐसे स्ट्रक्चर को या ऐसी मसल को स्पिंक्टर बोला जाता है. सो हियर व्हेनेवर द क्रिकोफेरेंजियस मसल इज गोइंग टू कॉन्ट्रैक्ट, द अपर इसोफेजियल ओपनिंग इज गोइंग टू close. That is the reason why it is called as the upper esophageal sphincter or it is called as the cricopharyngeal sphincter. वैसा ही एक sphincter होता है at the lower part of the esophagus when the esophagus connects with the stomach. When the esophagus connects with the stomach at the gastroesophageal junction, at this gastroesophageal junction we also have another sphincter. That is what is called as lower esophageal sphincter. That is what is known as lower esophageal sphincter. ठीक है, we'll talk about the sphincters later. पहले एक बार कंस्ट्रक्शंस देख लेते हैं. नाउ यू माइट हैव स्टडीड इन एनाटॉमी कि जो इसोफेगस होता है बच्चे, उसमें देयर आर 4 कंस्ट्रिक्शंस या कंप्रेशन, बिकॉज इसोफेगस के आसपास कोई ना कोई स्ट्रक्चर जा रहा होता है जिसकी वजह से इसोफेगस क्या हो जाती है, थोड़ी सी नैरो हो जाती है. इट इज कंप्रेस्ड. ओके, सो दीज आर कॉल्ड एज कंस्ट्रिक्शंस ऑफ द इसोफेगस. अकॉर्डिंग टू एनाटॉमी डेफिनेटली देयर आर हाउ मेनी कंस्ट्रिक्शंस in the esophagus? There are 4 constrictions in the esophagus according to anatomy. But according to surgery definitely our constrictions are important for what? हमें ये constrictions की जरूरत क्यों होती है? Because we have to pass an endoscope. जब हम अपर जी एंडोस्कोपी करेंगे बच्चे, when we pass a endoscope definitely inside the esophagus during upper GI endoscopy, at that time with the help of an endoscope we are able to see 3 constrictions. Okay, we are actually coming across usually the 3 constriction. The reason is the second and the third constriction almost they are at the same level. थोड़ा बहुत डिफरेंस होता है, but almost we consider them at the same level in surgery. तो अगर हम सर्जिकल की बात करें तो 3 कंस्ट्रक्शन, बट ओवरऑल एनाटॉमिकली कितने होते हैं? 4 constrictions are there. Got it? Important is the first constriction which is there, as you can see, it is nothing but the same cricopharyngeal sphincter. क्योंकि you have to remember this cricopharyngeal sphincter which is there at the pharyngoesophageal junction, this cricopharyngeal sphincter, it is going to cause narrowing of the esophagus, and as there is narrowing of the esophagus, this will be considered as the first constriction of the esophagus. And we have to remember that this cricopharyngeal sphincter, it is this cricopharyngeal sphincter, it is located at which level? So all of you rightly termed, it is located at the C6. Okay, it is located at the level of C6. That means at the level of the 6th cervical vertebra. So esophagus usually starts from the 6th cervical vertebra. Okay, that is the first constriction. And for endoscopy, definitely we should know that how much is the distance from the upper central incisor. ये जो teeth होता है, यहाँ से लेके उस first constriction तक का distance कितना होता है? So the first constriction is 15 centimeters away from the upper central incisors. Got it? Next important constriction which is there, bache, it is due to the arc of aorta. It is due to arc of aorta. Now, when the arc of aorta takes a turn, it is going to compress the esophagus from outside, and that causes the second constriction of the esophagus. It is usually 22 to 25 centimeters away from the upper central incisors. Okay. And then the third constriction which is there, the third constriction, it is at the level when the left main bronchus is going to compress the esophagus. As the left main bronchus compresses the esophagus slightly, it is going to cause the third constriction that you have to remember. It is usually 27 centimeters away from the upper central incisors. It is approximately 27 centimeters away from the upper central incisors. And lastly, the final constriction, the fourth constriction of the esophagus which is there, bache, the fourth constriction of the esophagus is going to be 40 centimeters, usually 38 to 40 centimeters away from the upper central incisors, and this is at the gastroesophageal junction. That means when the esophagus passes via the diaphragm, when the esophagus usually passes via the diaphragm at the diaphragmatic opening, due to diaphragm, definitely the esophagus will be compressed somewhat. Yes, so that is what is the fourth constriction. Okay, so these are the important things that you have to be aware of. So let's write down them over here in the table once. So as I've told you, C6 which is there, it is the first constriction. It is known as the cricopharyngeal sphincter. And we have to remember that this cricopharyngeal sphincter which is there, bache, it is not only the narrowest part of esophagus, rather it is the narrowest part of your whole GIT. Yes, cricopharyngeal sphincter is the narrowest part of your whole GIT. This will be important in foreign body when we'll talk about the management. Okay? C6 or the cricopharyngeal sphincter, definitely this one, the first constriction, it is 15 centimeters away from the upper central incisors. The next one which is at the level of T4, this T4 is due to crossing of arc of aorta. This T4 constriction, T4 level pe jo constriction hota hai, it is due to the arc of aorta crossing the esophagus. It is usually 22.5 centimeters to be exact. Okay, so usually they say 22.5 centimeters to be exact, 22.5 centimeters away from the upper central incisors. Okay. Next, the third one which is there, it is at the level of T5. This is when the left main bronchus crosses the esophagus. When the left bronchus crosses the esophagus and it compresses the esophagus from outside, then definitely the third constriction which is formed, it is how much away? It is usually 25 to 27 centimeters away from the upper central incisors. It is usually 25 to 27 centimeters away from the upper central incisors. And last constriction that you have to remember, bacho, the last constriction is at the level of T10. Okay. This last constriction T10 which is there, it is when the esophagus passes via the diaphragm. When the esophagus usually passes via the diaphragm, that is the diaphragmatic opening for the esophagus, bache. Okay, and that is going to compress the esophagus. It is at the level of almost 40 centimeters from the upper central incisors. Okay, it is 40 centimeters away from the upper central incisors. Okay, it is very important for us in the endoscopy. You have to be aware of these constrictions. Okay? Now important is esophagus which is there, it is actually divided into three parts. Yes, the esophagus is divided into three parts depending on its location, depending on its blood supply. Okay, क्योंकि इन तीनों parts का blood supply और venous drainage, they are different. The arterial supply and the venous drainage will be different for all these three parts of the esophagus. Okay, if I talk about the first part, see, the part of the esophagus which is usually related to the neck, that is called as a cervical part. Very short part is there actually. So the part of the esophagus which is present inside the neck, known as the cervical part of the esophagus, you have to remember that the cervical part of the esophagus receives its blood supply from the inferior thyroid artery. Yes, the same artery which was supplying the thyroid as well as giving some branches to the parathyroid gland, the same inferior thyroid artery will also supply the cervical or the part of the esophagus inside the neck. Okay? Next, the venous drainage will be in the same vein, inferior thyroid vein. Then the next part of your esophagus is the major part, where definitely the esophagus is usually present inside the thorax. This is called as the thoracic part. So the thoracic part of the esophagus is the longest part definitely. Here it will be supplied by direct branches of the esophagus from the aorta. Direct esophageal branches from the aorta. Yes, direct branches will be arising from the aorta to supply the esophagus. Which part? Thoracic part. Drain into which vein? It is going to drain into a main vein known as the azygous vein usually. And lastly, the part of the esophagus. Okay, you have to remember the part of the esophagus which is there below the diaphragm. The part of the esophagus inside the stomach, or we can say inside the abdomen or below the diaphragm, bache. This part of the esophagus, this is usually supplied by the left gastric artery. This is supplied by the left gastric artery. This is very important artery. याद रखना. Reason is ये artery याद रख के चलनी है अपने को. ठीक है? Reason is important is this artery which is there, which is supplying the lower part of the esophagus. बच्चे, it is the most common vessel to be ruptured, or this is the most common vessel to be ruptured in a case of Mallory-Weiss tear. जब हम Mallory-Weiss syndrome या Mallory-Weiss tear करेंगे, when a patient has a lot of vomiting, at that time there is stretching and that causes rupture of this left gastric artery itself. ठीक है, तो वो याद रखना, वहां पे बताना. Next important is this venous drainage for the intra-abdominal part of the esophagus. It is actually done in the left gastric veins usually, which will drain into the coronary veins. And these coronary veins which are there, they are going to finally drain into the portal veins. These coronary veins which are there, they are going to finally drain into the portal vein. These are not the heart wala coronary veins, okay? So that is different. So these are the left gastric veins. इसको coronary भी कहा जा सकता है. These are the left gastric veins, or we can call them the coronary veins definitely, and they are going to drain inside the portal vein. So important is, please tell me if the pressure inside the portal vein increases. If the pressure inside the portal vein increases, definitely will there be increased pressure in these left gastric veins also? Yes, there will be increased pressure in the left gastric veins because both of them are connected with each other, right? So in a patient of portal hypertension, definitely, when there is increased pressure in portal veins, there will be increased pressure in these lower esophageal veins known as the left gastric vein. And what is that condition called as, bache? So if the pressure in these lower left gastric veins increases, they will become dilated and they will become tortuous. आड़े टेढ़े हो जाएंगे वो, definitely टेढ़े मेढ़े हो जाएंगे, and they will become dilated, एकदम swollen हो जाएंगे. What is that called as? Dilated and tortuous veins in the lower part of the esophagus. Very good. It is known as esophageal varices. तो जब esophageal varices पढ़ेंगे, so please tell me which veins were responsible. ठीक है? Which veins were responsible. ठीक है? Got it? So that's the basic idea that you have to understand. ठीक है? चलो, very good. Esophageal varices बोलेंगे उनको. Very good. Now let's talk about the two sphincters of your esophagus. If I talk about the two sphincters of the esophagus, you have to remember there is an upper esophageal sphincter and a lower esophageal sphincter. The upper esophageal sphincter which is there, you call it as the cricopharyngeal sphincter as well, right? You call this sphincter as the cricopharyngeal sphincter as well. As I've told you, it is the narrowest part of the GIT, not only the esophagus but rather the whole GIT. It is the narrowest part of the GIT. It is the narrowest part of the GIT. And you have to remember one important thing. As I've told you already, it is at the level of C6 that we have already discussed. Important is this cricopharyngeal sphincter which is there. It is anatomical as well as a physiological sphincter. अब ये क्या बला होती है? What do I mean by this term? It is anatomical plus a physiological sphincter. That means बच्चे, anatomical sphincter, that means a narrowing. Okay, anatomical narrowing is present. Okay, due to that there is constriction. So that is what is the anatomical sphincter. Physiological sphincter matlab due to presence of the muscle, okay, there is high pressure at the zone. That is what is called as a physiological sphincter. Lagging हो रहा है अभी भी? सही चल रहा है. Okay, so please remember anatomical and physiological sphincter it is. Please remember बच्चे, the upper esophageal sphincter or the cricopharyngeal sphincter which is there, definitely you have to remember it is anatomical as well as the physiological sphincter. It is known as the anatomical as well as the physiological sphincter. Reason is, if there is anatomical narrowing, that is anatomical sphincter. If there is a muscle which contracts, and due to that there is increased pressure at that level. That is a physiological sphincter. यहाँ दोनों काम होते हैं. There is anatomical narrowing also and the muscle also which generates a lot of pressure. ठीक है? If I talk about the lower esophageal sphincter, बच्चे, the lower esophageal sphincter is a only physiological sphincter. The lower esophageal sphincter which is there, it is only a physiological sphincter. That means at that level there is no narrowing as such. At that level there is no narrowing. As you can see, this is the area. ठीक है? ये जो area है, this, just a minute, I'll highlight it with another color. This area which is there, this is what is your lower esophageal sphincter. Can you see this lower esophageal sphincter? Leave behind the diaphragmatic opening. Diaphragmatic opening is not a part. Okay? The lower esophageal sphincter is below the diaphragmatic opening. Can you see in this lower esophageal sphincter there is no anatomical narrowing. There is only a muscle. There is only muscles which are going to have increased pressure. ठीक है? And वो pressure कितना होता है lower esophageal sphincter का? You have to understand and you have to remember that the pressure at the lower esophageal sphincter is important. The lower esophageal sphincter pressure is important. Normally it is 8 to 25 millimeters of mercury. The normal pressure at the lower esophageal sphincter is around 8 to 25 millimeters of mercury. Important is now, please tell me if the lower esophageal sphincter is very, very high. If the lower esophageal sphincter is very, very high. Okay, why it is high? Because your muscles which are there at the level of the lower esophageal sphincter, they are not able to relax. If the muscles fail to relax, if the muscles at the lower esophageal sphincter, they fail to relax, हो गया शायद ना वापस नहीं स्क्रीन गई. Hopefully now it will improve, bache. See, important is, please tell me in the chat box now. See, I am saying that the muscles at the lower esophageal sphincter, they are not able to relax. As they are not able to relax, they are in constant spasm. वो हमेशा spasm में ही ऐसे, ठीक है? They are in constant spasm. They are blocking the esophagus, ठीक है? So that is the reason the patient is not able to eat anything. There is dysphagia, ठीक है? This condition where the lower esophageal sphincter fails to relax, definitely the pressure at the lower esophageal sphincter will be very, very high. Okay, the pressure at the lower esophageal sphincter will be more than 25 millimeters of mercury. What is this condition called as? Please tell me. When the lower esophageal sphincter muscles are not able to relax, they fail to relax, therefore they are in constant spasm. Okay, they are in constant spasm. The pressure is more than 25 millimeters of mercury. Very good, Akhil. It is achalasia cardia. It is achalasia cardia. Yes, 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 all of you. Right. Swapnil, Gokul, all of you. Very good, Piyush. So it is achalasia cardia because as you can see, definitely the muscles of the lower esophageal sphincter are not relaxing. They are in constant spasm and therefore the pressure is very, very high and therefore the patient is having difficulty in eating anything. That is what is called as achalasia cardia. Very good. And इसके opposite उल्टा, इसके opposite पूरा उल्टा. Now I am saying कि the lower esophageal sphincter muscles which are there ना, they are relaxing very frequently. वो थोड़े-थोड़े time में relax हो रहे हैं. Okay, the lower esophageal sphincter muscles are relaxing very frequently, and as they are relaxing very frequently, the acid from the stomach is going inside the esophagus again and again and again. Okay, so as these lower esophageal sphincter muscles are relaxing very frequently, therefore too frequent relaxation is causing reflux of acid from stomach inside the esophagus, and that is what is called as gastroesophageal reflux disease known as GERD. Very good. That's the important thing that you have to be aware of. याद रखना. Okay, so if I talk about this, अगर ये ज़्यादा relax होता है, if it relaxes too much, then definitely the patient will have GERD, and if it does not relax, then definitely the patient will have achalasia. The patient will have achalasia cardia. ठीक है? So that's the basic idea. Okay. Now, can anybody tell me two important questions from anatomy? Previous year questions, one-liners. Esophagus lacks which layer? Normally, we know there are 4 layers in the GIT. I have told you. The innermost layer of the GIT wall is known as the mucosa. फिर आता है submucosa, which contains your nerves and the vessels. ठीक है? So the innermost layer is mucosa. Second is the nerve and vessel containing layer known as submucosa. Third is the muscularis. And fourth is the serosa. Fourth is the protective fibrous coating known as serosa. So mucosa, submucosa, muscularis and serosa. So please remember, you have to remember that the outermost covering known as serosa is absent in the esophagus. So instead of that, do we have a covering? Yes, we do. But that is a very thin covering, and that covering will be called as adventitia. ठीक है, तो याद रखना esophagus के level पे बच्चे, we do not have any kind of serosa. Okay, it will be present in all other parts of GIT, but not in esophagus. Over here we have a very thin layer known as adventitia. ठीक है, yes, very good. So please remember, you have to remember कि submucosa कुछ लोग बोले, please remember that submucosa which is there, it is absent in the gallbladder. ठीक है, I'll come to that when we will talk about gallbladder. So you have to remember this, esophagus lacks which layer? Esophagus lacks the serosa. This has been a previous year question. Instead of that, we have adventitia. ठीक है, strongest layer of the GIT has been asked in the previous year question. So strongest layer of GIT is definitely submucosa. Strongest layer of GIT is definitely submucosa because it is made up of fibers, right? A lot of fibers. It is definitely the submucosa, has been a previous year question again. Now if I talk about the three openings in the diaphragm, there are three openings in the diaphragm. I hope all of you are quite aware. See, some structures have to go from thorax into the abdomen and some structures have to go from abdomen into the thorax. ऊपर से नीचे और किसी को नीचे से ऊपर जाना होता है. So for that definitely we have a partition between the thoracic cavity and the abdominal cavity known as the diaphragm. There are two domes of the diaphragm. So there should be a partition between the diaphragm बच्चे. Okay, so great. So important is definitely there are three openings in the diaphragm. So for example, if I consider this is the diaphragm, right? This is the central tendon of the diaphragm and this is the muscle of the diaphragm. Okay, this is the muscle of the diaphragm. Can you see definitely there are three openings in the diaphragm? I'll just highlight them. This is the first, this is the second, and this is the third opening. Here they seem at the same level, बच्चे, but they are not at the same level exactly. So the opening that you can see in the central tendon of the diaphragm, ये जो दिख रही है, in the central tendon of the diaphragm, this opening is present at the level of T8. This is for the inferior vena cava. The second opening that you can see actually at the junction, this is known as the esophageal opening, which is present at the level of T10. The esophagus passes via it. And lastly, this is the opening when the muscularis part of the diaphragm. This usually membranous part, muscularis part. This usually is the aortic opening present at the level of T12. This is for the passage of abdominal aorta. No issues with this, anybody, बच्चे? That is important. क्या हो रहा है इसको? Hopefully now it's visible. Hopefully now it's visible, बच्चे. Okay. Now if I talk about these openings from the lateral aspect, so you can easily see their difference. Okay, they are at not the same level, they are actually at the different level. See, important is the opening which is present in the central tendon is the vena cava opening. It is for the passage of inferior vena cava at the level of T8. Next important, this opening which is present at the junction, it is the esophageal opening at the level of T10. It is for the passage of the esophagus. And third opening which is there, it is present in the membranous part of the diaphragm. This is at the level of T12. This is the aortic opening from which the aorta is going to pass. Got it? That's the important thing. Now if I talk about this, bacho, as you can see from the lateral aspect, these three openings in the diaphragm, they're not present at the same level because we know diaphragm is a dome-like structure. Therefore, these openings will not be at the same level. The first opening, the vena cava opening, is present at the level of T8 vertebra. Okay. The second is the esophageal opening. It is present at the level of the T10 vertebra. And last is the aortic opening, which is present at the level of T12 vertebra. ठीक है? Vena cava opening सबसे आगे, then in middle we have the esophageal opening, and सबसे पीछे we have the aortic opening. Got it? Now let's write down. They can be easily remembered with the mnemonic Voice of America. We know that. Voice of America का मतलब क्या? Definitely. Okay, Voice of America I'll write over here. Voice of America मतलब V for vena cava, O for esophagus, America for aorta. ठीक है? That means first opening at the level of the first opening which is available at the level of T8, it is for the vena cava. The second opening at the level of T10 for the esophagus, and the third opening at the level of T12 for the aorta. The opening at the level of T8 bachche is known as the vena cava opening, and what passes via it? It is the vena cava opening, and what passes via it is actually the inferior vena cava and the right phrenic nerve. What passes via it is actually the inferior vena cava and the right phrenic nerve. It is the inferior vena cava, the right phrenic nerve. Got it? Next important is at the level of T10. At the level of T10, the opening which is present is known as the esophageal opening. And in this esophageal opening, definitely, which structures are going to pass? From this esophageal opening, there will be passage of the esophagus. Obviously, there will be passage of the esophagus. The second one which will be there, okay, the second structure which will pass is the right and the left vagus nerve. Both the vagus trunks will pass. The right and the left vagus nerve. And the third which is there, which will supply. Voice नहीं आ रही है? Am I audible? Hopefully I'm audible, बच्चों. Okay, great. Chalo. So please remember at the level of T10, we have the esophageal opening, and from the esophageal opening, definitely there is passage of esophagus. Then there is right and the left vagus nerve which passes, and the third one which is there, bache, the third one which is there, it is the artery which is going to supply the lower part of the esophagus. And which is the artery that supplies lower part of the esophagus? It is the left gastric artery. So the third structure which passes is the left gastric artery as well. It is the left gastric artery. Got it? So three structures which pass is the esophagus, right and the left vagus nerve, and the left gastric artery. Okay? And the last one that we have at the level of the T12, we have the third opening known as the aortic opening. And from the aortic opening, there will be passage of three things. First is definitely the aorta. Second important which is there is definitely the azygous vein. Second important which is there, it is actually the azygous vein. And the third one which is there is known as the thoracic duct. The third one which is there, it is the largest lymphatic duct of the body, which actually collects lymph from both the lower halves of the body as well as from the left upper half as well. Okay, right upper half se nahi karti, wo collect. That is the largest lymphatic duct of the body known as the thoracic duct. Got it? So these are the three important openings in the diaphragm of a patient. Three important openings. Okay? So that was about the basic anatomy. That is important for you to remember because questions have been asked on that. Now if I talk about some congenital anomalies of your esophagus, bache. If I talk about the congenital anomalies of your esophagus. The first congenital anomaly. Congenital matlab the condition which is present since birth is what is called as congenital. Anomaly matlab where there is an abnormal development, that condition is called as an anomaly. Okay, that is a defect in short. Okay, congenital anomalies की अगर मैं बात करूं, the first condition we are going to talk about is esophageal atresia. Now, what is atresia, बच्चे? Atresia matlab no development. The esophagus has not developed completely. As the esophagus has not developed completely, there is absence of some part of the esophagus. Yes. So, in esophageal atresia, it is nothing but there is absence of some part of the esophagus, not the esophagus completely, but some part of the esophagus which is there, it is absent because the development was not completed. Now, for example, see, we usually have the anterior pipe known as the windpipe or your trachea. Then we have a posterior pipe, that is your food pipe or your esophagus. Important is both of them are actually developing from the same lumen. Both of them are actually developing from a same lumen. And then there is a partition which develops between them. This partition which is there is known as the tracheoesophageal septum. This partition which develops between them is known as the tracheoesophageal septum. So this tracheoesophageal septum is developing, but while it is developing, okay, it is not developing straight. In some people or in some children, what will happen? This is going to get deviated posteriorly. As it gets deviated posteriorly, can you see? As it gets deviated posteriorly, definitely the esophagus which is there, it gets blocked. It is not developing further now. Okay, so lower part of the esophagus will be developed, and the lower part of the esophagus will be developed, but the upper part which was there, definitely it will not be completely developed. Okay, and it gets blocked somewhere in between. Now can you see some part of the esophagus is missing over here? Some part of the esophagus is missing over here. That is what is called as esophageal atresia. So esophageal atresia means, you have to remember, definitely it is absence of the some part of esophagus. Why does it occur? Because during development, when there was a partition which was developing between the trachea and esophagus in the form of the tracheoesophageal septum, that tracheoesophageal septum was deviated posteriorly, and due to that the esophagus development stopped in between. Okay, got it? So that is important. That has led to esophageal atresia. It is due to posterior deviation of the tracheoesophageal septum. Got it? Important is बच्चे now there are multiple associated anomalies with the with esophageal atresia. There are multiple types of other congenital anomalies which can be seen in a patient suffering from esophageal atresia, and these together are called as the bacterial anomalies. Okay, this has been a recent question and multiple times asked in the exam, so please be aware of this. What are the bacterial anomalies? Bacterial anomalies are all the congenital anomalies which can be present in the same child together. Yeah, they are associated with each other. So V goes for vertebral defects. Okay, V usually goes for the vertebral defects. You have to remember V goes for the vertebral defects. Then A goes for the anorectal defects, so the anorectal malformation. The anus or the rectum of the child is not properly formed. A goes for the anorectal defects. Then C goes for the cardiac defects. C goes for the cardiac defects. TE goes for the tracheoesophageal fistula. TE goes for the tracheoesophageal fistula. Now, as you can see, definitely, if there is formation of esophageal atresia, in that condition, there will be an abnormal connection between the trachea and esophagus also. That leads to formation of a tracheoesophageal fistula. Then there is renal agenesis. R stands for renal agenesis, and L stands for what? L stands for the limb defects. Okay, the patient can have limb defects. Can anybody tell me, out of all the bacterial anomalies, which will be the most common one? Can anybody guess that? This has been a previous year question. Which is the most common type of bacterial anomaly? That was a previous year question. Which is the most common bacterial anomaly? कौन सी लग रही है? किसके बारे में हमेशा सुनते आ रहे हो? हमेशा cardiac defects बच्चे. Cardiac defects. Cardiac defects are the most common bacterial anomalies that you have to remember. Okay, the most common bacterial anomalies are usually your cardiac defects. Okay, they are the most common congenital anomalies which are present. Okay, so that is the important one. That has been a previous year question. Now, usually if they ask you with with esophageal atresia, which is commonly associated, so we know already that with esophageal atresia, if the esophagus is not developing properly, if there is some problem in the development of the esophagus, there are very high chances that the patient can also have an abnormal connection between the trachea and esophagus. Abnormal two-way connection between two organs. A two-way connection between two organs is known as a fistula. Therefore, this is what is called as a tracheoesophageal fistula. So, esophageal atresia can be commonly associated with tracheoesophageal fistula, and depending on that, definitely we are going to classify this esophageal atresia into 5 types. Now, what is these 5 types? First is type A. In type A, you have to remember, bacho, in type A, the patient is only having absence of some part of the esophagus. Absence of some part of esophagus is known as esophageal atresia. So type A is nothing but esophageal atresia itself. Type A is nothing but esophageal atresia. Is there any fistula? Can you see any abnormal connection between trachea and esophagus? No. So type A is nothing but only esophageal atresia. Now type 2, if I talk about type B. In type B, what is seen definitely? In type B, some part of the esophagus is absent. That means the patient is definitely having esophageal atresia. But along with esophageal atresia, can you see there is a abnormal connection between trachea and esophagus? Yes. So definitely there is an abnormal connection with trachea and esophagus. That is what is a tracheoesophageal fistula. But that abnormal connection is with which part of the esophagus? The proximal or the distal part? The proximal part. So can we call it as the proximal tracheoesophageal fistula? Yes. So if the patient has esophageal atresia, plus a proximal tracheoesophageal fistula, that is type B. Next is type C. Type C is important. Type C, can you see there is absence of some part of the esophagus? Yes. So the patient definitely has esophageal atresia. But along with esophageal atresia, can you see that the distal part of the esophagus is communicating with the trachea? So can we say there is a distal tracheoesophageal fistula? Yes. So in type C, there is a esophageal atresia with a distal tracheoesophageal fistula. Okay, this is important, as I've said you. Why? Because type C is considered as the most common type. Type C, almost 80% cases. The most common type of esophageal atresia and tracheoesophageal fistula is type C. When there is a esophageal atresia plus a distal tracheoesophageal fistula, distal part of esophagus communicating with trachea. Next is type D, bache. In type D, what is usually seen? In type D, can you see there is absence of some part of the esophagus? Matlab esophageal atresia is definitely there, but along with esophageal atresia, there are fistulas in both the parts. There is a fistula in the proximal part as well as the distal part. So in type D, there is a proximal as well as distal tracheoesophageal fistula. There is a proximal as well as a distal tracheoesophageal fistula. No issues with this, anybody? That has to be remembered. In type C, definitely there is esophageal atresia plus a proximal and distal tracheoesophageal fistula. And last is type E. जो type E होता है बच्चों, please remember this type E which is there. Here can you see there is the complete esophagus is present. So is there any esophageal atresia? No. The complete esophagus is present. There is no esophageal atresia. Only what is there? Only a tracheoesophageal fistula is present. Okay. So this type E which is there, here only we have a tracheoesophageal fistula, and this is called as a H type of fistula. Can you see it makes a H shape? Therefore it is also called as a H type of fistula. It is also known as a H type of fistula. Got it? That is type E. Okay, तो जल्दी से esophageal atresia, only esophageal atresia type A, only tracheoesophageal fistula type E. ये तो easy हो गया. Now in middle, okay, so type B is what? Esophageal atresia but a proximal fistula. Type C is what? Esophageal atresia with a distal fistula, most common type. And type D is what? Esophageal atresia with both fistula, proximal as well as distal. Easy. That's important. Next important, if I talk about what will be the clinical features of the child suffering from esophageal atresia. Okay, याद रखना. Can we suspect that the fetus might have esophageal atresia during pregnancy itself? Yes. How? Definitely, bachche, I hope all of you are quite aware. The child is in the amniotic cavity or in the amniotic sac, and in that amniotic sac there is a lot of amniotic fluid. The major contributor to the amniotic fluid is the fetal urine. But ये जो amniotic fluid है, it is maintained at a particular level. It is not increasing too much. Why? Because the fetus keeps on swallowing that amniotic fluid. The fetus keeps on swallowing that amniotic fluid. वो निकलता रहता है वो fluid. तो इसीलिए ज़्यादा amniotic fluid नहीं होता. Okay. But in this patient, there is a esophageal atresia. The esophagus is not completely formed. So can the fetus swallow that amniotic fluid? No. The fetus cannot swallow that amniotic fluid. So all that amniotic fluid will remain in the sac itself. And ज़्यादा होगा या कम होगा इसमें amniotic fluid? Definitely there will be ज़्यादा, more amniotic fluid in the sac. And what is that condition called as? When there is excess amniotic fluid in the sac? Very good. That condition is known as polyhydramnios. ठीक है? So if a female during pregnancy is suffering from polyhydramnios, one of the causes of polyhydramnios, rather the most common cause of severe polyhydramnios बच्चे are gastrointestinal anomalies itself. तुम गाइनी जब पढ़ोगे you will study that the most common cause of याद रखना most common cause of mild to moderate polyhydramnios is idiopathic, but most common cause of severe polyhydramnios are usually the gastrointestinal anomalies like esophageal atresia or duodenal atresia. ठीक है? So please remember most common cause will be polyhydramnios itself during pregnancy. कोई दिक्कत नहीं है बच्चे, that has to be remembered. So pregnancy में the patient is having polyhydramnios, please suspect that the fetus might have any gastrointestinal anomaly like esophageal atresia. ठीक है? Now how are we going to suspect that the child has esophageal atresia at birth? कैसे पता लगेगा? At birth definitely there will be continuous drooling of saliva from the baby's mouth. Definitely, okay. This baby is not having a complete esophagus. Therefore, all that saliva which is there, the baby cannot swallow that. All that saliva will keep on coming out from the baby's mouth. There is continuous drooling or pouring out of saliva from the baby's mouth. Okay. And if we try to do suctioning, I hope all of you are quite aware, once the baby is born, we go for a suctioning of all the secretions from his mouth and from his nose. There will be increased secretions as well. बहुत ज़्यादा secretions आ रहे होंगे, ठीक है? Because the saliva is not able to, the baby is not able to swallow the saliva, ठीक है? Apart from that, the child will have respiratory distress. कब? When the child is actually having this condition, क्या हो जाएगा? If there is a fistula, definitely. If there is a fistula, you have to remember this saliva which is there, it is not able to go inside the esophagus. This saliva is not able to go inside the esophagus. So all that saliva will come inside the trachea. As all that saliva comes inside the trachea, from there it goes inside the lungs, definitely. Okay, the patient will have aspiration. All that lungs will be blocked. All the airway will have a lot of fluid. And as the airway is having a lot of fluid, the child will not be able to breathe properly, and that causes respiratory distress as well. Okay? So this child, two important signs as birth. First, continuous drooling of saliva is a classical hint that they give. Okay, and second, respiratory distress. Okay? Now, as soon as you suspect that the child might have a case of, because the mother was having polyhydramnios, and now there is continuous drooling of saliva from baby's mouth, also is having some respiratory distress. So as soon as you suspect that the child might have some esophageal atresia, you are going to perform an initial bedside test. And what is that initial bedside test, बच्चे? Try to pass. Try to pass. Immediately take a nasogastric tube or a Ryle's tube, or we can take a orogastric tube. For neonates, usually we have a orogastric tube that we are going to insert via the oral cavity. Okay? Try to pass a OG tube or a NG tube, whatever you have. Try to pass a orogastric tube or a nasogastric tube. Okay? But when you try to pass the orogastric or the nasogastric tube, you are going to get a resistance after a while. Why? Because this tube which is there, bache, it will go till a distance, but then after that it is going to coil up, and as it coils up, definitely you are going to get a lot of resistance. You are not able to pass the tube further. So usually that distance is 10 centimeter. You can pass the tube till 10 centimeter, and then definitely you will get a lot of resistance. Maybe you can force it, it will keep on coiling up over there, but it is not going further in the esophagus. You have to remember that if you get a resistance beyond 10 centimeter, that is a classical hint of esophageal atresia. So you can try to pass the nasogastric or the orogastric tube, and there will be resistance beyond 10 centimeter. There will be resistance beyond 10 centimeter. Okay? That is the classical initial bedside test that we do. Next important, if I talk about the initial investigation, बच्चे. Okay, initial investigation. उसमें क्या करेंगे? When we have passed the nasogastric tube, to confirm whether there is any coiling of this nasogastric tube or not, we are going to do what? We are going to do a chest X-ray of this child. When we do a chest X-ray, recent exam question, जान का था शायद ये. Yes. In this chest X-ray, can you see definitely the child is having coiling of the nasogastric tube inside the esophagus? This one that I'm highlighting. Okay, so definitely coiling of nasogastric tube or the orogastric tube is seen inside the esophagus, and that is the definitive hint definitely that the child is having esophageal atresia. So initial investigation is nothing but a chest X-ray which shows a what? Which is going to show us coiling of the nasogastric tube. It is going to show us the coiling of tube. So definitely on a chest X-ray, if you are able to see, बच्चे, on a chest X-ray, if you are able to see coiling of the tube, that is classically a hint of esophageal atresia. मैं अभी तक hint क्यों बोल रहा हूँ? Because बच्चे, we cannot just based on the X-ray, we cannot confirm it to be a case of esophageal atresia. उसके लिए definitely we have to go for better investigations which are available, and the investigation of choice which is there, it is actually a CT with contrast. Yes. So CT with contrast will be considered as the investigation of choice, okay, for a case of esophageal atresia or a tracheoesophageal fistula. But this contrast, if there is a fistula which is present, this contrast can also go inside the trachea and the lungs. That is the reason why you have to use a water soluble contrast. Don't use any water insoluble contrast or a contrast which can cause damage. Okay, so water soluble contrast like iohexol can be used in the patient only. Okay, so that's the important thing. Then type E जो है बच्चे, type E में there was only fistula. Type E में there was only fistula. So in that condition, these tests might come out to be negative. Okay, the initial bedside test which was there, passing a nasogastric tube, you will not get any resistance क्योंकि तो esophagus तो पूरी है उसमें. Okay, you will not even get what? Coiling of the tube which is there. Okay, so in this definitely CT with contrast से भी बेहतर होगा that you go for a tracheoesophagoscopy. That means you pass an endoscope inside the trachea and the esophagus and you look for a fistula, presence of fistula. That is called as tracheoesophagoscopy. So the investigation of choice for type E esophageal atresia and a fistula will be tracheoesophagoscopy. No issues with this, anybody? That's the important thing. Now if I talk about the management of the patient, you have to remember in this child, as the esophagus is not formed, the child will not be able to drink even milk or okay, the child will not be even able to drink milk. We have to keep the child on IV fluids and nutrition, okay, that is parenteral nutrition till we do a surgery. That is the reason why here this is considered as an emergency and we have to do the surgical correction on the first or second day of life itself. Yes, we have to do a surgical correction on the first or second day of life itself. Okay? If I talk about this condition now, what is the treatment or what are the surgeries that we do? For type A, bachcho, what was type A? Only esophageal atresia. What was type A? Only esophageal atresia was there. Now, if there is only esophageal atresia, there is no fistula. So fistula का तो tension ही नहीं है. Only esophageal atresia is there. Esophagus are not connected to each other. What are we going to do? We are just going to take both these ends and we are going to connect it with them. We are going to connect them with each other. अगर हम दोनों को connect कर रहे हैं बच्चे, we are actually doing a connection between two things. This is called as anastomosis. This is what is known as anastomosis. One part of esophagus connected to another part. This will be called as esophageal anastomosis. Or I can even call it as esophagostomy. Why stomy? Because I am creating an opening between them. right? So this is esophagostomy that I'm doing over here. ठीक है? That is usually done when the two ends of the esophagus are very close to each other. दोनों के बीच में ज्यादा गैप है क्या? नहीं. So you can just pull them थोड़ा सा and you can tie them to each other. So two ends are close to each other. We can go for esophagostomy. We can go for a esophagostomy, or I can even call it as the esophageal anastomosis. Esophageal anastomosis. No issues with this, anybody? That has to be remembered. Next important you have to remember बच्चे, if the two ends are very far away from each other. ये जो दो ends है, they are very far away from each other. Now can you pull them towards each other and can you tie them? No, we cannot do that, right? If the two ends are very far away from each other, definitely we have to wait for some time. अगर these two ends are very close, इसमें तो esophagostomy कर देंगे. But if the two ends are very far away from each other, for example like this, so if the two ends are very far, we have to wait for some time so that these two ends will grow towards each other, and then we can go for an anastomosis or a connection. ठीक है? And that is done by, for that time, till that time definitely बच्चा जिंदा कैसे रहेगा? So till that time definitely we have to wait for months ना. So till that time we are going to go for what? Can we give IV fluids till that time? No. For such a longer period we should not keep the patient on parenteral nutrition. ठीक है? We have to give enteral nutrition. Okay, enteral nutrition देना है तो definitely RG tube वगैरह, your nasogastric tube or orogastric tube cannot be inserted because the esophagus is not complete, right? In that condition, therefore, we are going to directly insert a tube inside the stomach. What was that called as? That was called as gastrostomy. I hope all of you are quite aware. Feeding gastrostomy, when the patient needs nutrition for more than 2 to 3 weeks, right? And definitely the gastric motility is normal. In that condition, here we are going to do a feeding gastrostomy. So here, if the two ends are far from each other, you have to go for a gastrostomy. We have to go for a gastrostomy, feeding gastrostomy for the purpose of nutrition. And thoda nutrition aa jaye bacche mein, when the size of the child increases, definitely the two ends grow close to each other. Okay, till that time wait for few days. We have to wait for few days, and then we are going for a esophagostomy or esophageal anastomosis. Okay, esophagostomy or esophageal anastomosis. No issues with this, anybody, bache? That is important to be remembered. Now if I talk about the type B, C and D. Now type B, C, D and E. In all of these, what was common feature? Every type was having a fistula. Every type was having a fistula. So इसमें fistula का भी तो सोचना है अपने को, right? So it is depending on the birth weight of the child and the presence of pneumonia. So usually I am not going into that depth. I am just telling you how to manage the child. इतना deep में वो नहीं पूछते. It is more important for your surgery exams. मतलब जब ये होगा final years. Important is depending on the birth weight of the child. That means whether the child is normal in weight or the low birth weight. ठीक है? If the child is normal in weight, you can go for the surgery immediately. But if the child is having low birth weight, less than 2.5 kgs का weight है, and there is presence of pneumonia, then you have to give antibiotics to the child. You have to give some nutrition to the child, and then after few days you have to go for a surgery. ठीक है? It depends on the birth weight, and the surgery which is done, that surgery has a common name. It is called as the Cameroon head surgery. Okay, उस surgery का नाम क्या है बच्चे? It is known as the Cameroon head surgery. Now what do we do in this Cameroon head surgery? In this Cameroon head surgery, first of all we cut the fistula. सबसे पहले we cut the fistula, then definitely we repair the fistula. Okay, we actually just repair the fistula and we close both the openings which are there. And lastly, we are going to repair the esophageal atresia by esophagostomy. Then finally, we are going to correct the esophageal atresia by esophagostomy. No issues with this, anybody? Esophageal anastomosis will be done. Okay, esophageal anastomosis will be done lastly. So cut the fistula, repair the fistula, and then go for esophageal anastomosis. That is what is called as Cameroon head surgery. That is done for type B, C, D and E of types of esophageal atresia. Got it, bache? That's the important thing. That is the surgery that we are going to do. The most common complication of the surgery which is there, initial complication which is there, it is usually an anastomotic leak. जो तुमने anastomosis बनाया वो leak करने लगा. That is the most common early complication. But late complication क्या होगा? जो तुमने anastomosis बनाया था, you have applied sutures over here. You have applied sutures over here ना. Now that sutures are causing fibrosis, and due to fibrosis, definitely there is a stricture which is formed. There is narrowing which is there. ओके, सो लेट कॉम्प्लिकेशन कैन बी अ स्ट्रिक्चर. जब भी एनास्टोमोसिस करते हैं बच्चे, मोस्ट कॉमन अर्ली कॉम्प्लिकेशन विल बी अ लीक एंड मोस्ट कॉमन लेट कॉम्प्लिकेशन विल बी अ स्ट्रिक्चर. ये गांठ मारनी है अभी से एक बात गांठ मार लो. जब भी तुम कनेक्शन कर रहे हो, एनास्टोमोसिस कर रहे हो दो चीजों के बीच में, मोस्ट कॉमन अर्ली कॉम्प्लिकेशन कैन बी अ लीक, मोस्ट कॉमन लेट कॉम्प्लिकेशन कैन बी अ स्ट्रिक्चर. गॉट इट? दैट्स द इंपॉर्टेंट थिंग. द नेक्स्ट वन विच इज देयर बच्चों is what is known as the another congenital anomaly. The another congenital anomaly which is there, it is known as the congenital diaphragmatic hernia. ठीक है? If I talk about congenital diaphragmatic hernia बच्चों, important is we know, see, the thorax and the abdomen both are separated by these domes of diaphragm. Okay, they are both are separated by the domes of diaphragm definitely. So if there is some problem in the diaphragm, normally there are three openings in the diaphragm that we have studied: the vena cava, the esophageal and the aortic opening. But apart from that, if there is a defect in the diaphragm, apart from that there is another opening in the diaphragm or a defect in the diaphragm, what is going to happen bache? Therefore the abdominal organs like the intestine, for example the abdominal organs like the intestine, they are going to come inside the thoracic cavity. And when they will come inside the thoracic cavity, will your lung have enough space to expand? No, your lung will not have enough space to expand, and therefore your lung will get on compressing. As your lung gets on compressing bache, definitely there is a lot of pressure on the lung now due to the intestine which is present or the abdominal organs which are present in the thoracic cavity. Therefore the lung gets compromised, and that is the reason why definitely lung is not able to expand, and therefore the child experiences respiratory distress. That is the reason why the child experiences respiratory distress. Second, all the abdominal organs are actually coming inside the thorax. तो अगर पूरे के पूरे organ are coming inside the thorax, can you see the anteroposterior diameter of the thorax is increased? Can you see the anteroposterior diameter of the thorax is increased? So increased anteroposterior diameter of thorax is what is called as the barrel chest. So this patient is going to have a barrel shaped chest. Third important is, यहाँ पे, can you see over here? This is the abdomen of the child. All the abdominal organs are going inside the thorax. Therefore, the abdomen of the child appears to be scooped out. ऐसा लग रहा है ना किसी ने आइसक्रीम का स्कूप लिया इसमें से. So it appears to be a scooped out abdomen. That is called as a scaphoid abdomen बच्चे. As all the organs are going in the thorax, it appears to be a scooped out or a scaphoid abdomen. ठीक है? That is important to be remembered. And last important feature, as definitely there are all these abdominal organs are going to come inside the thorax. All these abdominal organs are going to come inside the thorax. Your heart which is there, तुम्हारा दिल जो है, this heart will be pressed towards the left side, right side. This heart which will be there, this heart is pushed towards the right side. The heart is pushed towards the right side, and right sided heart will be called as dextrocardia. Okay, that will be the third feature. So now let's talk about this congenital diaphragmatic hernia बच्चों. If I talk about the congenital diaphragmatic hernia, you have to remember it is nothing but due to a defect in the diaphragm, or diaphragm is formed by which membrane? So you have to remember diaphragm is formed by a pleuroperitoneal membrane. Easy है नाम कैसे? Pleuroperitoneal. The membrane that separates the pleural cavity from the peritoneal cavity is what is called as a pleuroperitoneal membrane, and that pleuroperitoneal membrane which is there, it is further leading to formation of the diaphragm. ठीक है? So if there is defect in the pleuroperitoneal membrane itself, or there is a defect in the diaphragm itself, therefore the abdominal organs are called as viscous as well, right? Viscous बोल लो or visceral organs बोल लो. So these visceral or the viscous organs are going to protrude, or they are going to come inside the thoracic cavity. That is what is the case of congenital diaphragmatic hernia. In simple terms, what is hernia first of all? Hernia is nothing but protrusion of a viscous or a part of the viscous from the wall which contains it. मतलब जो इंटरनल ऑर्गन होता है वो बाहर की तरफ आता है उस वॉल से जिसके अंदर वो प्रेजेंट होता है. ठीक है? फॉर एग्जांपल इंटेस्टाइन इज कमिंग आउट ऑफ द abdominal wall. That is what is a hernia. वैसे ही the intestine is going out of the diaphragm. ठीक है? That is what is a hernia again. So as it is present since birth, it is congenital. As it is due to a defect in the diaphragm, it is diaphragmatic. And because there is protrusion of the organs outside their cavity, therefore it is called as hernia. So here there is protrusion of the viscous or part of it through the wall containing it. That means in the diaphragm. It is due to, as I've told you, it is due to, write down, a defect in the pleuroperitoneal membrane. It is due to defect in pleuroperitoneal membrane. This is a classical feature that you can remember with the mnemonic RDS, the one that I have explained it to you right now. Okay, classical triad which is there bache of your congenital diaphragmatic hernia can be remembered with RDS. Okay, respiratory distress syndrome. Okay, सो आरडीएस के साथ ट्राइड याद रख सकते हो. सबसे पहले डेफिनेटली एज द लंग इज गेटिंग कॉम्प्रोमाइज ड्यू टू द abdominal organs in the thorax, patient is having respiratory distress. As the heart is pushed towards the right side, patient is having dextrocardia. And third, as all abdominal organs are coming into the thoracic cavity, therefore the abdomen appears to be scooped out, and that scooped out abdomen is known as a scaphoid abdomen. So these are the important features that you have to be aware of, बच्चे. ठीक है? This have been asked. Now there are two types of congenital diaphragmatic hernia. The two types of congenital diaphragmatic hernia, बच्चों, one is called as the Bosch-Dirac hernia, second is called as the Morgagni's hernia. जो Bosch-Dirac hernia होता है बच्चे, you have to remember it is the most common type of hernia. The Bosch-Dirac hernia which is there, it is a more common type of hernia. Okay, Bosch-Dirac is the most common type of congenital diaphragmatic hernia. This is a very common question. Okay, इसी पे question आते रहते हैं Bosch-Dirac पे. It is because it is more common congenital diaphragmatic hernia. ठीक है, या dextro means right. So Bosch-Dirac जो होता है, this is more common. Important is Bosch-Dirac hernia is on which side? तो याद रख लो, Bosch-Dirac hernia it is present on the left side. इसलिए मैंने left side पे दिखाया. Bosch-Dirac hernia is present on the left side due to a defect in the left part of the diaphragm. It is present posterolaterally. Posterolaterally मतलब पीछे की तरफ होता है थोड़ा. Okay, it is present in posterolaterally. उसके अपोजिट पूरा जो होता है वो Morgagni होता है. That means Morgagni will be present on the right side and it will be present in the anteromedial side. बीच में होता है, आगे की तरफ और बीच में. It is present anteromedially. So important is Bosch-Dirac, as I've told you, it is more commonly seen on the left side and it is present in the posterolateral wall. It is present in the posterolateral side or posterolateral wall, whereas Morgagni is present on the right side and it is present on the anteromedial wall. It is present on the anteromedial wall. Next important is you have to remember the most common organ which can herniate. The most common organ which can herniate, बच्चे, in Bosch-Dirac, the most common organ which herniates is nothing but the small intestine. In Bosch-Dirac, the most common organ which herniates is nothing but the small intestine. Okay, mainly it can be the jejunum. But क्योंकि duodenum is fixed, mostly it is the jejunum most of the times. ठीक है, वेलिया वही होता है. I'll come to that. Okay, and the most common organ which herniates in Morgagni, it is the transverse colon. Yes, the more common organ which herniates in Morgagni is actually the transverse colon. क्योंकि it is medial ना, यहाँ transverse colon होता है, तो easily आके ऊपर जा सकता है. ठीक है, but it is rare. Morgagni is rare though. ठीक है, that is important. Bosch-Dirac अच्छे से याद होना चाहिए. Left side बच्चे and posterolateral wall. ठीक है. Diagnosis is done by what? So definitely the first line investigation that we can do, if the child is having respiratory distress after birth, my first line investigation has to be a chest x-ray. So I'll do a chest x-ray in that child, and on that chest x-ray I'll be able to see what? A classical picture. क्या दिखता है मुझे chest x-ray पे? I'll be able to see a classical picture where all these bowel loops, normally intestine में क्या होता है? Intestine contains air or gas. Therefore these intestinal loops which are there, they are containing air or gas, therefore they appear black. Okay, so these intestinal bowel loops, these intestinal bowel loops which are there, can you see all of them are inside the thoracic cavity? Yes. And therefore are they compressing the lung? Yes. That is a classical case of congenital diaphragmatic hernia. This is important. This is very commonly given X-ray in your examination when bowel loops herniate or the bowel loop shadows are usually seen inside the thoracic cavity. Okay? So the chest X-ray classically shows the bowel loop shadows. It shows the classical bowel loop shadows in thorax. Okay, it classically shows the bowel loop shadows in thorax. No issues with this, anybody? Bowel loop shadows in the thorax will be seen in the patient. Okay? For confirmation, we can even go for a CT scan further. For confirmation, I can go for a CT scan. Okay? That has to be done. Next important is definitely, if I talk about the treatment, what should be done? For this condition, I have to close the defect, and after reducing the herniated organs, I have, first important, मैं क्या करूंगा इस कंडीशन में? जितने भी organs thoracic cavity में, I'm going to push them down back into the abdominal cavity. Yes, I'm going to bring all these herniated organs back into the abdominal cavity, and once I bring all these abdomens back into the abdominal cavity, बच्चे, then I'm going to close what? Then I'm going to close the defect definitely. Then मैं इस defect को close कर दूंगा. If it is a small defect, I can just close it with the help of sutures. If it is a very small defect, I can just close it with the help of sutures. But if it is a large defect, I need to place a patch over here. If it is a large defect, bache, then I need to place a patch over here, and that can be a prosthetic patch. That can be actually a prosthetic patch. ओके जैसे मैश यूज करते हैं ना हर्निया में, वैसे ही यहाँ पे वी आर गोइंग टू यूज अ प्रोस्थेटिक पैच यूजुअली, ठीक है, टू क्लोज दैट डिफेक्ट. सो वी हैव टू क्लोज द डिफेक्ट आफ्टर रिड्यूसिंग द herniated organs. If there are larger defects, as I've told you, we use a prosthetic patch for the closure. Now, what is contraindicated in this condition? Usually, if the child is having respiratory distress, what are we going to do usually? We are going to give the child, if a neonate is having respiratory distress, we try to resuscitate the neonate with the help of ambu bag. I hope all of you are quite aware. Ambu bag jo hota hai, it is used to deliver the air or oxygen to the child. There is a mask to it and there is a bag to it. Therefore, it is also called as bag and mask ventilation. Important is, बच्चे अगर तुम bag and mask ventilation इस बच्चे में दोगे who is having congenital diaphragmatic hernia, he will not have improvement in his respiratory distress. Rather, there will be worsening of his respiratory distress. Why? Because अगर तुम directly उसके मुंह और नाक के through उसको, okay, if you are giving it via mask, therefore air is going to the air is going inside his nose, but the air is also going inside his mouth, and definitely from the mouth it is going inside his esophagus, from esophagus into the stomach, and from stomach it is going inside the intestines which are present in the inside the thorax. From stomach it is going, all this air is going inside his intestines. Now क्या होगा, ये जो intestinal loops है, all these bowel loops or all these intestinal loops, they will dilate further, they will get distended, और हवा भर जाएंगे उनमें. All these bowel loops which are there, they will get distended further, and as they get distended further, they are going to compress the lung more. As they compress the lung more, बच्चे, definitely due to that reason, the patient will have worsening of respiratory distress. That is the reason if a child is suffering from congenital diaphragmatic hernia, don't give a bag and mask ventilation, क्योंकि अगर mask लगाओगे, air will go via his mouth till his intestines, and there will be more dilatation or distension of intestine, causing more compression of the lungs, right? Therefore, this has been a previous year question quite a number of times. What is contraindicated in a child of a congenital diaphragmatic hernia is a bag and mask ventilation. Okay, it is a bag and mask ventilation, important. It is absolutely contraindicated. No issues with this, anybody? That is important. And कैसे intubate कैसे ventilate करेंगे बस बच्चे को? Definitely with the help of ET tube. Endotracheal intubation should be done. Reason is endotracheal tube will directly deliver the air inside his trachea only. Don't use even a nasal cannula or something like that. Directly go for an intubation, because from there only the air will directly go inside his trachea. Otherwise, it will go inside his esophagus. That should not happen. Most common cause of death क्या होती है बच्चे? Most common cause of death क्या होती है? So it is the lungs are not able to develop in this child, and there is underdevelopment of the lung. Underdevelopment of the lung is known as pulmonary hypoplasia. Hypoplasia is nothing but underdevelopment. So pulmonary hypoplasia, that is underdevelopment of the lung, is the most common cause of death. अगर lung develop ही नहीं होगी बच्चे की, the child will have severe respiratory distress, due to which the child is going to die. Due to which the neonate or the child is going to die. That was all about your congenital diaphragmatic hernia and the congenital anomalies of the esophagus. Please let me know in the chat box, do you want to continue with GERD today, or do you want to do it tomorrow? Okay. Okay. No issues with this. Okay, that's fine. Okay, tomorrow we'll do it. Chalo. Tomorrow we'll do it. Please revise whatever content has been discussed today. Hopefully you have understood it. If you're having any doubts, definitely I'll be available. Don't worry about that. ठीक है? चलो बच्चों. Revise it, solve your MCQs, and let's meet tomorrow. I'll be informing the time tomorrow. Most likely it will be the same time. Yeah, because you are more active in the morning. आज there was much productive session in the morning itself. ठीक है? Thank you so much. My pleasure it is. Thank you all of you. हाँ जी. Thank you so much.